Foreign Policy's publisher and CEO, Andrew Solinger.
Good afternoon, everyone. How are we? Let's raise the energy level. How are we? Wonderful. Welcome to our very alive and awake in person, as well as our very alive and awake virtual audience. Thank you for joining us. The FP Health Forum. We have got a lot of great content for you. 5 hours of great content. But don't worry. We've chopped it up into manageable 90-minute to 2-hour blocks. You're going to enjoy it. It's important stuff. The first segment is on climate. That's what we're going to kick off in a couple of seconds. And health, very important intersection. Then we're going to talk about non-communicable diseases and what we're doing about those. And then we're going to finish off with a session and a series of discussions on AMR, which is, of course, a very important topic at this UNGA. It will be punctuated by short breaks where you'll have snacks, you'll eat sugar, you'll be re-energized, and you'll network. But then you're going to come right back in here and listen to more. And you will be rewarded at the conclusion by a wonderful cocktail reception and discussion with our presenting partner, GSK. Thank you, GSK, along with Global Antibiotic Research and Development Partnership, which is one of GARD-P, which is one of our supporting partners. Speaking of which, I want to thank all of our supporting partners, and it's a wonderful list. Amgen, AstraZeneca, Bupa, Cigna Healthcare, City Cancer Challenge, Environmental Defense Fund, Gavi, Merck, Pax Sapiens, Philips, Reckitt, Seed Global Health, and Viatris. You have postcards on your chairs. The agenda and speakers can be available via the QR codes there. And you also have FP magazines that are floating around as well. If you're not a subscriber, we have a handy discount QR code in there. You should sign up, and I will ask at the end if you have subscribed. So get ready for that. Thank you for coming. We have so much content to cover, so we're going to get right into it. Look forward to it. Thank you.
Please welcome Dr. Tedros Adhanom Ghebreyesus, Director General of the World Health Organization, and Dr. Vanessa Carey, WHO Special Envoy for Climate and Health and CEO of Seed Global Health, for a fireside chat with Foreign Policy's Editor-in-Chief, Ravi Agarwal, on the pathway to healthy planet and people.
Hello, everyone. Great to be back here. Thank you for being here. Thank you for spending time on this particular issue. And a big thanks to Dr. Tedros and Dr. Vanessa Carey for making time in their very busy schedules this week for us. Dr. Carey, I thought I'd start with you. We were just chatting earlier about how it's so easy for health to be siloed when, in fact, it is so connected as this underlying factor on every other discussion we have, and we're here specifically to talk about health and climate and how they interact. But tell us how you see that in your work around the world.
Absolutely. I think that without question, as we frame what's happening in climate change right now, climate change and health is not a new topic, just to start with. It's just an acceleration of existing health problems that we have failed to solve. And at the crux of those existing health problems is the reality that health is fundamental to everything that we do. It is quite literally the difference between whether or not you go to school, you can care for your child. It makes a difference as to whether or not your family lives above or below a poverty line. For a country, it is your GDP and your macroeconomic growth. It is migration, which is getting accelerated in climate change now, where we're expecting 1.2 billion climate migrants by 2050. That puts on a political pressure for resources. And so health is, we don't think in these terms all the time, which is why it's lovely to have health discussed at Foreign Policy. But that's what's so fascinating to me about the climate discussion. Because in climate discussion, we talk about it in terms of degrees Celsius averted, not in terms of lives saved. And at the crux of this, when we're talking about a phase out of fossil fuels, we actually have to talk about a phase out of fossil fuels and a just transition, because that is what is going to save lives. Millions of lives. It is going to be critical to our survival to mitigate that harm. And so we have a deep responsibility, I think, to stop thinking about health in a silo and to start thinking about how it relates across everything that we do. And at Seed, and I would argue beyond that, as we speak of silos, we address healthcare in silos too. We think in vertical problems rather than in thinking horizontally. We have an opportunity to accelerate our climate response, and we have felt this at SEED through focusing on health system strengthening and looking at the ways that we can meet all disease burdens. SEED has trained 42,000 doctors, nurses, and midwives in the last decade. And with our 2030 strategy, we're looking to 100,000 more. And we see them on the front lines of climate resilience. Because what they're doing, for example, family medicine physicians that we are training in Malawi and partnering with the governments to train in Malawi and Zambia, they can take care of 80% of problems, health problems that you see in communities, many of which are being driven by climate change. So that horizontal flexible response is our climate resilience. It is our adaptation, but we also have to make sure that we're thinking about the mitigation of harm in the first place, which is a phase out of fossil fuels, and that is critical to our health conversation.
That's really well put. Thank you. The question is how, and I'm going to build on that in a second, but Dr. Tedros, let me bring you in. How are you thinking about the immediate crisis of getting help to vulnerable populations around the world? And then you have a longer term crisis as well, which is building health resiliency around the world. Big challenges. I don't know where the money is, but push us towards solutions here. Where are they? What do you need to get that done?
Yeah, thank you. I think, first of all, thank you for this opportunity. I just came back from Sudan, and in order to see the refugee situation in Adre, this is on the border with Sudan, the Chad-Sudan border, I have been to Chad. And when we were flying in, we could see a flood, and the country is flooded, and more than 500 deaths, and millions have been, hundreds of thousands of people have been affected. The reason I wanted to tell you this is, first of all, the Sudan situation is very, very tragic. Half of its population needs food aid. A quarter of the population actually has been displaced. And what you hear there is horror stories, and Sudan is forgotten, and this is not right. So I just wanted to say that because this forum especially is very important. And then on Chad, the flooding means, climate change is real. I think that's where we should start. It's around us, meaning with flooding, for instance, it means cholera. With flooding means it could be malaria, dengue, and so on.
Dr. Tedros, if I may, this audience in particular is converted on this issue. We know climate change is real. We know the scope and scale of the problem. Push us towards solutions. What do you need? Where does the money come from?
Yes, so on the vulnerable, you said, first of all, it should be our agenda should be health-centric. And she said it, and I don't want to repeat. And then second, I think we should start from the most vulnerable, from the last. We need to focus on the vulnerable population. And then the third is we need to use the resources wisely, meaning targeting those populations, affected populations. And then from there, of course, you can move to the rest because resources are limited. But at the same time, the focus of the COP29 upcoming, I met the president this morning, their focus is on climate financing, which is good news. So how can we advocate aggressively to make sure that what the COP29 presidency is planning is happening, meaning successful resource mobilization, because without resources we cannot do the things you said. But I was really happy. But the other thing he said is, with the existing resources, the processes they have is very archaic. It takes a long time to get the resources. Even when the resources are there, you don't get it quickly. So the process should be improved.
How do we fix that?
No, now the presidency is committed to change that, to improve the processes so the resources can be expedited. I mean, the process could be expedited so those who need the resources can have it as soon as possible.
Got it. Vanessa, you're going to jump in.
I do want to jump in because I think when we talk about the solution, one, we cannot think in silos even in climate, right? we shouldn't be diversifying the climate conversation into mitigation and adaptation and resilience. We need them all, and they all come together, and there's co-benefits to both. And I think that that's a critical opportunity in COP29 to bring that forward as we talk about climate financing, we talk about human capital, and we build on what started in Dubai with a very strong pronouncement and launch of a health day and bring it forward into future COPs, which you'll hear about shortly. So we can't silo that conversation. But I just came from the UN this morning where I heard the Deputy Minister of Health for Mozambique note that 90% of his health facilities are highly vulnerable to climate change. How do you provide services for a population, keep them safe, and be able to actually ensure that they have the opportunities they need, the resilience to protect them in the way that the WHO has been doing such an extraordinary job for a long time? And it's through accountability. And the truth is, we have to be more accountable as we sit here in our chairs in New York as a community. The resources exist in this world. We just aren't mobilizing them, and we're not mobilizing them fast enough, and we're not directing them to vulnerable populations. At COP28, $1 billion was announced for climate and health. Over 800 million of that was already earmarked and already pre-spent. We have to be honest, too, about what we're doing and honest to our partners in Mozambique, and we have to be able to deploy the money flexibly and quickly behind country-led plans. This is possible. We are doing this through the Lusaka agenda and really trying to read through financing that goes behind country-led. And we have to, again, I think in the same way that Dr. Hedges was also pointing out, is to take the health conversation out of its health silo and introduce it deeply into the climate debates. It needs to be embedded in the NDCs. We need to have health metrics, and we need to stop thinking about it as a sunk cost, but rather as an investment.
Dr. Tedros, let me bring you in on that.
So I would like to add to her, maybe.
Please.
I don't know if you're asking the same thing, but resources, as she had said, are not the problem. The priorities of our leaders are the problem.
Yes.
For instance, the defense expenditure, staggering 2.4 trillion US dollars. If you take that, what we're asking for climate change, it's a rounding error compared to the defense spending.
I'm with you, but I'll point out every conference I go to these days, they're asking for more defense spending, not less.
And that's what
This
I'm
is
saying.
defense.
So the sad part is,
great point.
in many of the meetings I have attended, leaders proudly announcing that they're increasing their military expenditure. Proudly. Few years ago, was embarrassing to say that. Now, but of course there are conflicts. If they're thinking that they can only solve it through military means, they're wrong. Instead of spending all this money for the wrong reasons, it's better to find political solutions. Political solutions. By the way, the most courageous choose peace. So they should push in that direction. And we need leadership for that. Otherwise, we have resources.
I'm with you on that, Dr. Tedros. And most of what I cover as a journalist is conflict these days. And you're right, people want more defense spending because they see that as an existential crisis. What you're saying is so true in that healthcare spending is defense spending. And I wish we could reframe that. Let's try and reframe it together. One last quick question to you, Dr. Tedros. The pandemic was really rough on the world. I think it really hurt trust in countries and in their sense of equity in the global system. You know what I'm talking about. You've written about this for FP. Just tell us quickly how you can re-inject more trust into the global system.
Trust into the global system is very, very difficult, especially with all the misinformation and disinformation. And the challenge we're facing now with the pandemic agreement, with all the misinformation circulating, I think everybody's witnessing it. This pandemic agreement is a negotiation between member states and for member states. And when agreed, it will be implemented based on their national laws. But what's circulating now is as if WHO is going to take over or WHO is going to be dictating lockdowns and so on, which will never happen because what is circulating is actually a lie and a misinformation. So the solution for this, for instance, because trust should be tailored to some specific issues, the member states should come out and say this is a negotiation between us, for us, and we will implement it based on our national law. And there is nothing that will be a world government, that some people are saying, that will dictate or, what do you call it, tamper into their democracy. So I think for trust to come, the member states themselves, the 194, should come and say it, tell the truth. Then, at least, if everybody says it in their respective countries, trust could come. But many countries are quiet, almost all of them, to be honest.
Yeah.
They're quiet, despite all the misinformation that's circulating. We cannot say it, WHO, because WHO is not negotiating, or we're not the one who is going to write the negotiations. It's the member states, belongs to the member states, and the member states should defend it. And it's in each country, whatever they say and do, telling the facts that can bring back trust, and how this pandemic agreement can help in preventing the same crisis like COVID from happening. They should tell them, and they should promise that, because that's the intent of the agreement or the treaty, to prepare the world to prevent the next pandemic.
I couldn't agree more. Unfortunately, we're out of time. There's always this moment where your clock is counting down and then it starts counting up. I want to say just two quick things before I let you go. One, I often write and talk about how the UN is paralyzed. It is, but conversations like this give me a lot of hope. And second, I think what Dr. Carey said is going to stay with me for a while, and that is that healthcare is defense. It's a good defense. And I think that's something we should try and popularize because it's a great line. Thank you very much to Dr. Tedros and Dr. Carey. Thank you in the audience.
Thank you.
Please welcome Professor Maha Taisir Bakara from the United Arab Emirates Ministry of Foreign Affairs, Elmar Mamadov, the Senior Negotiator and Co-Lead of the Action Agenda Initiative Team for the COP29 Presidency, and Ethel Maciel, Secretary of Health Surveillance and Environment, for a conversation moderated by Foreign Policy's Andrew Solinger on aligning climate goals with health outcomes.
Hello and welcome everyone. We have an important topic we want to discuss right now, and that is building on the momentum of the first ever Health Day at COP. That was in UAE, and there's a critical need to keep it on the COP agenda, especially as we head into Baku for COP29. And luckily for us, we have the Health COP Troika with us, and so we're very excited to be speaking with them. Maha Barakat is Assistant Minister for Health and Life Sciences at MOFA of the UAE. Elmar Mamadov is Senior Negotiator and Co-Lead at COP29. And Ethel Leonor Noya Maciel is the Secretary of Health at Brazil. Welcome back. We spoke last year at our Health Forum. I wanted to point out that Maha may have to leave a little bit early. She's been called to a ministerial and needs to boogie back to the UN. So we're going to go straight to you, Maha, and talk a little bit about what we learned at the first ever COP Health Day in the UAE last year. That was an important moment because climate change is incredibly threatening to global health systems, and there's an urgent need to take concerted actions, and there's no better place to do that than at COP. Tell us a little bit about that day, what actions were taken, and what potentially could be improved. Thank you, and good afternoon, everyone. So it actually didn't start on the day in November last year. The discussions had been building up from Fiji 23 to Glasgow COP26 with the Attach Coalition created. And then when it came to Dubai COP28, it was really the logical next step. It's just we needed to ensure it happened. And we put all our efforts with many partners, particularly the WHO, to ensure that one whole day was dedicated to health, covering
issues that are related to the climate health nexus. That was the first time, and on that day we held the ministerial. We'd expected a few dozen ministers to come. We had over 108 health ministries represented. There was a declaration that was prepared. Again, the WHO told us, we can aim for 50 signatories. You'll be lucky if you get 50. We ended up with over 150 signatories to this health climate declaration. And what's so wonderful is that with our colleagues here to my left, we're going to have a COP day at Baku, and we're going to have a COP day at COP30 in Brazil. And they say that once you have 3 consecutive COPs holding some event, it's now embedded, it's enshrined, it's going to happen forever. So this is fantastic news. This is really wonderful news. And going back to Dubai, so on that day, in addition to the declaration and the ministries, there was a pledge of $1 billion to be used for climate health issues around the world. And I think at the end of the day, what do you look for? I mean, why are we doing this? Ultimately, it has to be to save lives. It's not about numbers and, gigatons of this or emissions. It's really about how many lives can be saved as a consequence of the initiatives that will be put in place as a consequence of these COPs. And if we had to give three comments or 3 kind of topics that need to be taken forward. Firstly, we would say for the nationally determined contributions, please institutionalize targets for health in there, and be they things like the impacts of air pollution on health, be they heat stroke, be they mental health issues, number of events prevented, whatever they are, please institutionalize certain metrics of health inside your nationally determined contributions. Secondly, we've seen how many agendas are very important to the WHO and the UN. Last year's pandemic treaty, which still hasn't been signed, this year antimicrobial resistance, and now we've started non-communicable diseases building up for over the next 52 weeks for next year. These are all issues these are all agendas that can be under the umbrella of climate and health. They all impact health and are impacted by climate. Add to it universal health coverage, add to it gender, add to it poverty. So there are several agendas that actually overlap with the climate and health nexus. And we should maximize the opportunities to remind everyone to include health in that. And then finally, the funding aspect. We can't do any of this without more pledges, and we're really hopeful that there will be more pledges at Baku and in Brazil. And very interesting discussions over the last 2 days. On Monday, one eminent economist was saying, the health community needs to put a number. What are we talking about? What's the number that the health community needs to make a difference for climate and health issues? And then there were others that said, well, how do you define, what do you mean by health issues impacted by climate? What are they? Is it a small definition, or do you cast a wider net? And obviously, the wider the better. If you're going to include antimicrobial resistance, if you're going to include non-communicable disease, if you're going to include pandemics, the wider the better, and argue that actually climate is important to all of them. I'm sorry, I've talked a lot, but over from
all
you.
good. Thank you, Maha. Those are very good points, very helpful. And that's a good baton pass to Baku. You can applaud. I think that's appropriate. Very heartfelt. And as you know, we do not solicit questions from the audience live. It just takes too much time, and people don't use question marks at the end. But we do solicit them in advance. And we actually got a question for Elmar, and that question is squarely onto Baku. So this is from Marilyn Sanema, who is the Netherlands Vice Minister for Public Health. And she asks, as the Netherlands has been leading the new WHO resolution on climate change and health, seeking to integrate climate into the work of the WHO, we'd be interested to hear from the speakers and you, Elmar, in terms of follow-up on what you see as concrete opportunities for COP29 to help also better integrate health into the UN climate process.
Thank you. Thank you very much. I would like to inform you that we used 5 key principles for designing of COP29 presidency-led initiatives. First of all, to find balance between 3 pillars of climate agenda: climate finance, mitigation, adaptation. Second principle that we used is a balance between enhancing ambition and enabling action. Third principle, balance between 3 dimensions of sustainable development: economic, environmental, social. Number 4, to have in our list not only global initiatives, but also regional initiatives. And number 5, harmony between human and nature. And for particularly for integration of health, prioritizing health topic in our agenda, we have 2 important global initiatives. First of all, Baku initiative on human development for climate resilience. And under this initiative, we will tackle multi-sectoral synergy between education, health, jobs, skills, and children and youth. And second, most very important initiative on cities. It's a multi-sectoral actions pathways to resilient and healthy cities. We'll integrate the topic of health into the city planning issue. Under the first initiative on human development, also we have 2 important innovations. First of all, we would like to create a coalition of COP presidencies, continuity coalition of COP presidencies on climate and health topic, to bring together, starting from Fiji, UK, Egypt, United Arab Emirates, Azerbaijan, Brazil, to create such a coalition of COP presidencies, and also to try to keep this topic on a permanent basis on the climate agenda. Also, under the cities initiative, we have the same approach: creation of coalition, continuity coalition on urban climate action, also for cities front. That's why these 2 topics, 2 initiatives, we will tackle this issue, health topic. Also, we will tackle through the high-level round table One Health and human development topic.
Excellent. And it's not just, thank you for sharing all of those initiatives, and those sound many and important, but it's not just urban. Aren't you also targeting rural development as well with your Harmonia for Climate Resilience program? Could you explain that for a moment?
We have also initiative Harmonia, particularly for farmers. And also under the Harmonia initiative, we will tackle climate resilient village topic and farmers, particularly women and youth farmers, and health also will be one of the key elements.
Right, that borrows a little bit from the One Health initiative that we'll be talking about in AMR a little bit later. Secretary Maciel, let's move over to Brazil and look forward to next year. And I think that was great that Maha talked about making, after 3 COPs, it's permanent, right? It's written in ink.
Yes.
What steps can Brazil's COP30 leadership take to prioritize health and climate discussions? Similar type of initiatives? It's early, but what types of discussions and initiatives are being talked about?
Thank you. We start with the G20 presidency, that we put a declaration in climate change and with One Health approach, looking specifically for AMR. And we are working this declaration with G20. We expect that next October we will finish this declaration. We are in negotiation right now. And the next step is to bring all this declaration to the COP30 in Brazil. Brazil is putting in the climate change a lot of the working in equity for health, because this is what we are seeing in Brazil in the last 18 months that we are in this new government. We create under my Secretary of Health and Environment, this new name, environment, came from health. And the secretary was more abroad right now. And we have a specific coordinator to work with climate change and equity in health. We know Brazil was hit in this year for the biggest dengue epidemic forever. And this was very consequence of the climate change and the high temperature that we are facing in Brazil and in all of the world. So Brazil has a universal health system, is one of the biggest with the 200 million inhabitants in the world. And different from other countries, health is the second budget of the government. So it's a biggest budget. And nothing is enough. It's not enough, but it's the biggest, the second biggest budget from all the government. So this create opportunity to see all the impacts and create indicators that we can follow for the next year. We are seeing the increase of some infectious disease. I point out dengue. We saw an emergence of Oropouche fever that we have like a very few cases, and right now it's a problem. So we are seeing this difference. And right now what we want to do in the COP30 is put health as an argument for climate change, because climate change sometimes is abstract, but health can give a concrete indicator for this.
You're quite right, and you brought up some excellent examples, and we only have a few seconds left, but I wonder if we could also talk for a moment, Maha, and also Elmar, each of you, how your health systems are changing. Let's forget about COP, how your health systems are changing to take into account climate change and the impacts therein. And how much of your government budget is spent on healthcare versus Brazil's? Maybe, Maha, you could start us off.
So health, as in many countries, will take up either the number 1, 2, or 3 budgets in any local or federal government. And I think we are privileged in the United Arab Emirates to be able to allocate the appropriate funding in a very well-resourced country. We have universal health coverage. We have strong health systems. So the building blocks for what you need to be climate resilient are there. Never underestimate the importance of health system strengthening. Never underestimate the importance of very strong public health measures. Never underestimate the importance of universal health coverage. Everyone needs treatment.
Great. And Elmar, in Azerbaijan?
We are investing a lot to the health sector. We are constructing new green hospitals, and also we are investing to human capital in the field of health in our capital city in Baku and also in the regions. Health sector, it is one of the top priority for government. Human capital topic is top priority. And also, as I already mentioned, it is one of the important elements in our budget.
Excellent. We're out of time, but a great note to end on. I want to thank the COP Troika. Great handoff from the UAE to Azerbaijan and now to Brazil. Thank you for all the good work that you do. Please thank our panelists.
Thank you very much.
Next, please welcome Patty O'Hare for a fireside chat with our moderator, Maggie Lake, on health and climate resilience in cities.
Thank you so much. Already off to a fantastic program, and so important that we're putting that focus on the intersection of climate and health. And Patty, wonderful for you to be here, and let's dive right in because we got to make the most of this time we have. So let's talk about what do we need to think about in terms of cities sitting at this intersection. I think we kind of instinctively know that climate, air quality, big issue for cities, but how are you thinking about this?
Yeah, I think cities are at the coalface, really, of the climate crisis. And we know from what Vanessa said that climate crisis is a health crisis. It's a water crisis as well. But the proximity to cities, you really feel whether it's increasing temperatures, whether it's poor air quality, whether it's NCDs or communicable diseases that are on the increase, cities are really at the forefront of the climate crisis. And as we think about how the world is changing and where people are living, 50% of us today live in cities, but by 2050, that number goes up to 75%. And we know that the cities, as they're constructed today, are not really equipped for this kind of exponential growth. So if I just talk a little bit about a city, for instance, of Barcelona. Lots of people have been to Barcelona, fantastic city. But 60% of the public space in Barcelona is actually targeting cars and concrete. So as we think about more and more of us living in cities, we have to think about how cities need to evolve and change such that they can accommodate us in living. So that means in the case of Barcelona, 160 hectares will be dedicated to green spaces. It means 10 biodiversity shelters. So this is an important thing. So actually, when we're thinking about cities and climate and health, we're actually talking to different stakeholders than we used to. So urban planners as an important constituent for health.
Right. And to think Joni Mitchell wrote that song all those years ago, warning us about the parking lots. So bring in the health component of it. So I think that anyone who's lived in a city and has been through administrations that are trying to greenify, we're sitting in New York, we know there was a big effort. If you've been to the West Side, the High Line we understand trying to address air quality. What's the impact on health, and where do we need to think about changes in the health system? How can thinking about healthcare systems mitigate some of what we see that's going on? Where do they fit in the puzzle?
Yeah. Most of the climate discussions like at UNGA this week happen at a multilateral or a national level. So there are organizations of cities, C40 cities, climate resilient cities, et cetera, but they're not really thinking in terms of the nexus of climate and health. And so
that 40,000 foot conversation.
Yeah. And I think what we're advocating for is really kind of a bottom-up approach in addition to that top-down approach, because cities and city mayors have a unique perspective in the fact that they don't think in those silos. And I think, Vanessa, if I just pick up on Vanessa's point, which is we need to think horizontally in addition to those verticals. And city mayors, they think about education, they think about budget, they think about finance, they think about all of the different aspects of a city, and they have a unique perspective in terms of they've got the remit and they're innovating. Our cities are really innovating and leading the way. So I think we need to make sure that we're supporting our cities and our city mayors, because these folks are elected.
Well, they're accountable. I was just going to say, especially when we're talking about health, you can talk about large scale health problems, but if you have neighborhoods, if you have underserved communities, you're seeing the impact in real time. I think we all probably have anecdotal stories of things that happen if the highway is put in a certain place and there's too much air traffic. Can the healthcare, so what can those local officials, and with the powered by the community, because we know that helps scale solutions, what can be done there to address it? It seems like that's what happens. That's where they end up afterwards in the healthcare system. Yeah. How do we need to change the way perhaps we're thinking about that?
I would say what we need to do is we need to rethink how we think about healthcare. Right now, if you are sick or feel unwell, you go to your doctor and you potentially have to go to the hospital, God forbid, and then you get better and then you return to work. In this case, if we are reimagining and we're thinking about public health much more holistically, then your stakeholders are completely different. They're your educators, they're your pharmacists, they're your community healthcare workers, building healthcare resilience. We heard from Vanessa how important that is. But it's reimagining public health from a grassroots and what I call a place-based solution versus just a sick doctor situation.
Does that help solve how is that impacting climate? Does climate happen and then if we get to them earlier, we prevent worse outcomes? Or is it actually tied to climate in a more holistic way?
Well, we know, sadly, that 250,000 additional deaths will occur directly as a result of climate change, right? So we can talk about how we are going to decarbonize the healthcare system, the traditional healthcare system, and that needs to happen for sure. But the best way to decarbonize the healthcare system is to keep people well, right? So rather than treating a problem, let's, if we focus on prevention and a community or what I call a place-based approach, then we can keep people healthier longer and therefore reduce carbon emissions and keep people healthier. This case of Barcelona, what I'm talking about, their plan, they're adding through the implementation by 2030, they're estimating that people in Barcelona will live over 200 days longer than they would have previously. So they're adding real adjusted life days and years onto people's health.
And less intervention. If you're getting it early, there's less intervention. What are some other examples of how this is, people are addressing this, or how these programs are putting into place, and can it scale? I mean, Barcelona is a big place, so presumably that would be a good example. But what are you seeing that works for people who are out there who understand this problem, but who are perhaps looking for some examples to take back home to them, to their local leaders?
Well, I think every city is going to have different challenges and different infrastructure and different support systems. And I think what you have to start with is, if you take we're working with the SMI, the Sustainable Markets Initiative, and we're looking at London right now. And ULEZ, for those of you who've been to London, is a tax, if you will, to bring your car into the city. And this has been hugely controversial in London in terms of reducing air quality. And you also see the taxis have gone down to 20 miles an hour in order to improve air quality. Because we know, when we look at cities, we know that air quality is a determinant of health, right? And reducing pollution in the air is going to make everybody healthier. But yet there's a significant pushback often from people who live in cities who want to be able to have that access and have that transport. But I think the most important thing for me is, as we think about healthcare, we need to think about what are the sources of what's making people ill. And air quality, for instance, is responsible, and poor air quality is responsible for 3 of the top 5 health indicators in a city like London. So if you're not combating air quality or improving air quality, you're going to be dealing with the consequences of poor air quality, and that's only going to put further stresses on your healthcare system. And finally, I think it's really important for us as a healthcare community to think about the social determinants of health. When you think about the social determinants of health, actually up to 50% of health outcomes are a direct result of social determinants of health. So while we're thinking about decarbonizing the healthcare system on the one hand, that's fine, well, and good. But if you're not addressing the social determinants of health, your access to proper nutrition, your access to affordable housing, your socioeconomic drivers, these are all incredibly important aspects. So to sum up, for me, cities give you that kind of umbrella way that you can look at all of those aspects and make sure that you're spending your time, your effort, your energy around the social determinants of health, decarbonizing the healthcare systems, and thinking about public health in a much more holistic way.
Just really quickly, public-private partnerships sounds like it's critical. It's critical across the SDGs and any conversation about sustainability, especially when we bring the finance part in. But it seems especially so here.
Yeah, I think if we redefine public health as public health, then you're talking to educators, you're talking to pharmacists, you're talking to council leaders, urban planners. Whereas if you just talk about climate and health, that kind of puts you over in another category that's just talking about the health commissioner or the Ministry of Health in a silo. And what we need to do is we need to think more differently about that.
Fantastic. Patty, thank you so much. Appreciate it. Thank you all.
Please welcome Dr. Sonia Nishtar, Chief Executive Officer of Gavi, the Vaccine Alliance, for a conversation with Foreign Policy's Andrew Solinger on vaccines and climate adaptation.
Sonia, thank you for joining us. You're still the relatively new head of Gavi. since April. Is that correct?
It's a bit relative. I'm 6 months into the job.
Yeah.
So it depends on
Does that seem like 6 years, or how is that going for you so far?
Well, I've been thrown into the deep end, so it doesn't seem like 6 years.
It's very exciting. It's very important work. Congratulations, and thank you for everything that you're doing. We're going to talk about climate change and vaccines right now, and just to make sure we're all on the same page, recent analysis from the National Library of Medicine says that climate change has exacerbated over 217 infectious diseases worldwide through a variety of pathways, vector-borne, waterborne diseases, bringing pathogens closer to people. Malaria, which we'll talk about, a disease carried by mosquitoes, reported its first locally acquired case in 40 years in the U.S. state of Maryland last year. That's high on your agenda, I know. And we can go through a variety of different crises, but I'm really looking forward to you helping us to explore how vaccines can help combat climate-sensitive diseases. And would love to learn a little bit about how we can apply some of those learnings and how multi-stakeholder partnerships can help resolve this. So maybe just at the top, you could give us your summary on how climate change is impacting the spread of infectious diseases and the critical role vaccines play.
So climate change has got an inextricable relationship with vaccines in terms of prevention. Because what climate change does to pathogens and vectors is that it makes them behave in very unpredictable ways. So you have outbreaks where you don't expect them. The severity of outbreaks are totally unprecedented. You have emergencies and situations that are totally unexpected. And then with climate change come floods and droughts. And during flooding, waterborne diseases are a risk. Communicable diseases per se become a problem. And recently we've observed that due to floods, there's huge disruption of infrastructure. Primary healthcare facilities, hospitals, the field teams get totally immobilized. And that creates a huge problem. I come from Pakistan. Some of our colleagues here come from Pakistan. We've recently had terrible flooding. We're a country of 220 million individuals. And the last flood, which came in late 2022, actually inundated 1/3 of the population. That's horrific. And there were entire districts where villages were submerged underwater. Primary health care facilities were totally disrupted. Electricity, the cold chain. It was hell on earth. And we have a highway running through that district, which is a couple of feet high from the ground. And for miles, you could see poor communities sitting on that highway. And all we could do as a government and as humanitarian actors was to make trucks pass through that highway to distribute food and to distribute essential items. It was hell on earth. So this is what climate change does to impoverished communities. And I think the challenge is then, number one, in terms of our scope of work, to run preventive campaigns there. So cholera is a problem, running preventive cholera campaigns there. In Pakistan, for instance, the typhoid conjugate vaccine was planned for introduction, but that had to transform into an emergency operation.
Right.
And it's during times like these that you have to mobilize your stockpiles, and you have to mobilize operational funds, and to make sure that these emergency operations get underway in extremely uncertain and evolving environments. So the relationship between what we do and what climate change ushers in terms of devastation is real, it's palpable, it's playing out as we speak, and unfortunately, as temperatures rise, it's deeply worrying for us, because our scope of work is less routine immunization and predictable routine immunization, and more emergency response.
And then you're simply sticking your finger in a dike. I can imagine that getting out ahead of that. Interestingly, we were talking about earlier potential solutions, and I know that last night you hosted an event to talk about technology and innovation that can help with some of these challenges. I'd be really interested to hear if you could share with us. Tell us a little bit about that event, who attended, and what are some of the technologies that might help here that we could apply that you talked about and you could share with us.
Well, I wish we had a bigger room last night because it seemed like my wedding where there were less chairs and more guests. But it was an exciting event, oversubscribed, standing room only. I think the backdrop of this is that I come from an implementing country, and I'm interested in better delivery because I've seen the mayhem on the ground. And the institution that I lead now, that I have the privilege of leading now, has been very good at cutting-edge innovations. So Gavi is known for its IFFM and its vaccine bonds and its partnerships with the DFIs and the MDBs, which is something that I am furthering this week as well. And Gavi has been extremely astute at brokering the public-private partnerships, particularly with the pharmaceutical sector, to bring the cost of vaccines drastically down for our implementing countries. And I think that has been remarkable in terms of process re-engineering, partnership re-engineering. And I think what we need to now move towards is delivery innovation. And I think with some of the simple things, simple tools that we have at hand, we can really transform the way we deliver. I mean, for instance, we support, we spend over $1 billion in outbreak response over our strategy period. There are hundreds and thousands of health workers that are paid with a lot of hemorrhage and pilferage from the system. But mobile payments, for which the infrastructure exists everywhere, can change that. Again, for outbreaks, if we had better forecasting through predictive analytics, we could do a lot better. We have a number of different data streams in different pools and different clouds. Blockchain could overcome those inefficiencies. We're grappling with the issue of 10 million children who have not received a single dose of any vaccine. And clearly AI has huge potential to triangulate data from different sources to enable us to reach out. I'm not talking about the state-of-the-art things. These are things that are commercially available, but there is a market failure when it comes to the deployment of these technologies for the last mile, for the poorest communities. And part of what Gavi can do is to create those incentives, those AMCs, those pull mechanisms to get investors to invest. I mean, infant biometrics is something else that we talked about yesterday. Right. So delivery innovation was very much the...
So your VAX portfolio is going to expand into a delivery mechanism portfolio as well.
Well, you don't just deliver vaccines to the tarmac. No. You've got to get them into arms. And exactly, and that's very well articulated. It's reimagining the way you deliver. The private sector uses these technologies extremely well. I mean, yesterday I gave an example that even today, a woman in the remotest village can scan her retina, can use an ingestible pill to get her blood glucose level, can auscultate through a simple device. Her data can be thrown into a cloud, and Uber can be booked for her to go to a doctor, an appointment can be booked, her pills can be printed at the local pharmacy. And standalone, we have these technologies, but there has been no incentive to piece them together for solutions that can transform the lives of people at the last mile who need them.
Fantastic. Let's go back to financing for a second and talk a little bit about some of the tools that you're using there. And correct me if I'm wrong, that you are currently in the process of raising funding. I think you have something along, losing my notes here. Your plan is to raise $9 billion, I think, in your 6-year plan. You're at $2.4 billion, somewhere along those lines. And you're increasingly looking at vaccine bonds and some of the other tools that you've engineered. Maybe tell us a little bit about your strategy for bringing in that funding that's required. There's been a lot of discussion around funding today.
So Gavi, the mandate of Gavi is to provide access to vaccination for the poorest countries of the world. And over the last 2 decades, Gavi has vaccinated over 1 billion children. In the process, it's saved 17 million lives, and accrued 200 billion of economic benefits in the poorest countries of the world. And in our next strategy cycle, we want to amplify and accelerate our work. So the next 1 billion are going to be vaccinated in half the time, with an additional 100 billion worth of economic benefits additionally accruing. And this time around, you referred to the malaria vaccine. We have we have a far diverse portfolio of vaccines, 50% of which are relevant to climate change-related diseases. The malaria vaccine rolling out in 13 countries of Africa with a demand from 30. The tuberculosis vaccine on the anvil, the dengue vaccine, deeply relevant to climate change, is in our investment strategy. So, and of course, we are deeply relevant to global health security. I mean, we were able to order the Mpox vaccine just 35 days after the pronouncement of the global health emergency, as opposed to the months that elapsed subsequent to the COVID-19 pandemic. And all this will cost. So our ask for the next replenishment is 9 billion. But this 9 billion is to protect people, is to protect communities, and it's to protect the world.
And to generate economic benefit. I mean, there's clear ROI that you can raise. Well, that was an amazing summary of all the good work that Gavi does, and we're happy that you exist, and happy that you're leading it. A hand for Sonia Nishtar.
Please welcome Pam Chang, Executive Vice President of Global Operations, IT, and Chief Sustainability Officer at AstraZeneca, for a fireside chat with Maggie Lake on building climate-resilient health systems for NCDs.
Hi, everyone. So, Pam, as we jump in, I'm going to ask you to just repeat what you just said to me, because we were just chatting about work and jobs, and you hold many titles at AstraZeneca, but it was really interesting why you said that mattered. Just fill everyone in, because I think this is a fascinating point.
Yeah, so hi, everybody. Great to be here today. Pam Chang from AstraZeneca. So Maggie and I were just kind of having a casual conversation on the side there, and I said, really interesting to see how across different companies, how we do sustainability. Some, we have the CSO job as a standalone role. Some have a combined with operations role. So for me, I've got different day jobs. I'm the head of manufacturing, supply chain, procurement, and IT for AstraZeneca, and I'm also the CSO. And I find that it's such a privilege to be able to combine these roles, because it really allows us not to do sustainability as a side initiative or program. We literally build it into everything we do, from drug discovery to manufacturing to supplying to the patients. So it's pretty cool.
Which I think is so important, and I'm so happy to share that, because I think it does really bring home a lot of what we're saying has to happen now, that we're at this point where we recognize that this has to be early stage for everything. So we've been talking all about health.
Yes.
And we're going to talk focus a little bit. It's been brought up non-communicable diseases. So I think we understand the health impacts from climate. We are understanding it more after today. Talk to me a little bit about this area, because it seems like it's a little underappreciated.
Absolutely. So in Dubai last year at COP28, for the first time in history, we made the connection between climate crisis and human health. And I think that was such an amazing moment, because if you look at the statistics, there's data to prove that. There's 12 million people die, more than 12 million people die from pollution and extreme heat alone. And in last year's Lancet Countdown report, it's projected that if the temperature continued to rise versus the pre-industrial times, the number of deaths due to extreme heat will be increased by 370% in the future years. So it's there for us to see it. And we, in our industry, in the life science sector, we are in the business of making people healthy. And we see the rise of disease like respiratory, cardiovascular, and cancer. So it's hard to ignore that. It's happening. There's a direct link between non-communicable disease versus the climate crisis.
Yeah, and I was with someone yesterday who talked about a neighbor who had a generator blowing into their house, and neighbors, so air quality, you can't get more local than that. Absolutely. And all of them suffered from cancer. So it's that focus on those diseases that we don't really maybe connect with climate, because it it gets diagnosed for something else. So what do we have to do in order to prioritize this? What needs to be done? Where are we with the fight against that?
Maggie, that's $1 billion question, right? I mean,
And a very big one for
yeah,
the time we have.
Exactly, I'm watching time here. First of all, there's no magic bullet. There's no magical solution that's going to solve everything in a neat way. I think we think of it in two parts, right? The first part is, how do we decarbonize our end-to-end value chain, right? So, for example, in a healthcare sector, we contribute about 5% of global emissions. Now, you might think, Pam, it's 5%, it's not that high. It's high. It's bigger than the aviation sector. So it's a bit ironic where the healthcare industry is in the business of saving lives and making people healthy, but at the same time, we are contributing to the climate crisis, right? So I think the first order is, how do we stop contributing to the problem? How do we decarbonize? Absolute reduction. We're not talking about offsets or credits. We're talking about absolute reduction of decarbonization. How do we make sure we preserve nature and biodiversity? So I don't know if you guys know, but significant part, roughly 70 to 80% of the raw ingredient that goes into manufacturing of medicine, which is my day job, comes from nature. So how do we make sure we reduce that interdependency, that dependency on nature, stop contributing to the problem, and really restore and regenerate nature and biodiversity? So that's kind of the part one. Part two is really around health system resilience. If you look at health systems around the world today, significant number of them are under-resourced, overstretched, particularly post-COVID. Unfortunately, significant part of that burden are in the privileged populations and geographies like Africa, for example. It was estimated, WHO estimated the cost of climate-induced disease costs to the healthcare systems will reach about $4 billion per year by 2030. And guess what? 80% of it is shouldered by Africa countries. So really, we need to think about how do we reduce that healthcare system burden. And one of the things that we are being a champion of is, first, about prevention of non-communicable diseases. How do we help educate and raise that awareness and prevent these diseases? And then how do we make sure that there's early screening, early diagnostics, and early guideline-based treatment to keep patients out of hospitals, which is better for the patient, better for the healthcare system, and better for the environment.
Absolutely, and echoes with what Patty said. Not to mention, if you're spending all your money on treating people that are dying because of it, you have less money to invest earlier on in terms of making the transition and change. I want you to talk a little bit about Healthy Heart Africa, because the more specific we can be and give examples, people can take them away, maybe try to scale them, see if they work and apply to where you are. What's happening there? How do you feel about the progress? And do you think this is a lesson that others can take?
Yes, thank you for the question. So AstraZeneca has been really working on healthcare system resilience for a long, long time. We started Healthy Heart Africa as a program in 2014. And at the time, our goal was to really help with the burden of hypertension in Africa. And I'm super pleased to report that 9+ years later, we've actually conducted over 57 million blood pressure screening. We've identified over 11 million people with elevated readings, which means these are the folks that wouldn't have known they have hypertension potentially until the screening was made possible. We trained over 11,000 healthcare workers in countries in Africa. So now, fast forward to 10 years later, what we are doing now is we are evolving Healthy Heart Africa to focus on those diseases that are climate crisis induced and have tremendous amount of burden on the local healthcare system. So we're going to focus forward on heart and kidney diseases. And we've got 4 very specific objectives. We want to educate and raise awareness about heart and kidney diseases. We want to train the healthcare professionals in Africa. We want to provide the opportunity for early screening, early diagnostics. So for example, for a kidney patient, for example, a disease patient, if you find it early and you can keep their disease in check and prevent them from progressing their disease to a severe state, that ended up them in the hospital doing weekly dialysis, for example, which, by the way, is one of the most carbon footprint heavy treatment in the health system, for example. So early screening, early detection is super important. And then lastly, on the last bucket is how do we generate evidence and science-based data to support better policy making and help increase our resilience of health systems. We've got a very ambitious goal. So we want to be operational in 9 African countries by the end of 2025. So we're getting to work on it.
That's terrific. And that's the kind of program that when you can scale is going to make a difference.
Huge.
Private-public partnerships, incredibly important in this area. How are you able to execute on a program like that? I would assume you need local stakeholders involved.
Absolutely. So we've got, at AstraZeneca, if I may expand this a little bit, we've pledged over $1 billion in our Ambition Zero carbon program. Effectively, our goal is we will reduce our Scope 1 and 2 carbon emissions by 98%, absolute terms, by the end of 2026. I'm the head of operations. I feel the pressure, but good news is, as of end of last year, we've actually reduced Scope 1 and 2 by 67% already. So we are on our way to that. We will have our Scope 3 absolute emissions by 2030. We also pledged over $400 million in a program called AZ Forest. We are planting 200 million trees in 6 continents. And you might say, you know, it's about planting trees. Not really. It's above that because we are working with the local communities around nature, biodiversity, bringing jobs and livelihood to the local communities. Coming to your point around public-private partnership, we couldn't have done any of that stuff without partnership. I would say in the space of climate crisis, it takes all of us to act. You know, initiatives like the Sustainable Market Initiative, the Healthcare Task Force, actually chaired by our CEO, Pascal Soriot, we're trying to mobilize the industry and engaging with governments, communities, and experts, and the private sector to ensure that we can actually move solutions at scale. So can't do this alone.
Yeah, we know that. And I love those examples because I do think it is exactly the blueprint for others who are looking to try to do that, especially when it comes to partnering with local communities, because that's what's needed. They need the help, but if you can come in and get that local knowledge, then it certainly guarantees more success.
Absolutely.
And thank you so much.
Thank you.
Appreciate it. Thanks all.
Thank you.
Now, please welcome Sarah Vogel, Senior Vice President of Healthy Communities at the Environmental Defense Fund, for a fireside chat on mitigating methane.
Welcome back. Welcome, Sarah. Welcome to my home. No, it's wonderful. And Sarah and I have had the pleasure of doing panels before, and we were joking when I found out I was doing this one. I said, "Oh, you got me. This is a topic I think I know about, but I'm actually not that sure." And it turns out I didn't know nearly enough. So, if you would, Sarah, let's just set the stage because we're talking about methane, and I think many of you may be in the same position that you think about it, or at least in terms of one thing. So, what do we need to understand about this problem and the scope of it?
Yes. So let's just start with the basics. What's methane? Where is it coming from? How it impacts health.
Yes.
Maybe I'll just lay that out in 3 parts. So methane is referred to these days as a super pollutant. It can trap 80 times more heat in the atmosphere than carbon dioxide in the first 20 years that it's released. So estimates now look at potentially 30% of the human-caused warming that we're experiencing right now is attributable to methane. And the other interesting thing about methane is that it doesn't last in the environment as long as carbon dioxide. So it had been called a short-lived climate pollutant, but that's kind of a mouthful. So there's been a lot of effort to say that we need to cut methane now as we decarbonize, because it could be one of the fastest, most efficient ways to slow the warming we're seeing right now. So methane comes from really 3 big sources. Agriculture, that represents roughly around 40%, largely from livestock. So think about cows and other ruminants burping up their food that they've digested. and some from rice, oil and gas, which represents about a quarter, and then waste, largely landfills, but also wastewater. So maybe just then, okay, health. Should I go to health, or do you want to?
So I think, that I think is where my knowledge was. I know that it contributes to climate, but I wasn't aware of the health. Right. That's the bit that I was not as aware of. So what is the impact on health?
Yeah, and part of the reason I wanted to talk about this, or excited to talk about this, is it's really the theme that everyone's been discussing today, which is we need to take a One Health or an integrated approach as we think about climate, both mitigation and resilience. So there's sort of two pathways we think about it. One is the warming that we're seeing, right? And many people have talked today about the impacts of that warming on health, from extreme weather events to shifting infectious disease. We heard a lot about that, to deteriorating water quality and air quality. So there's that aspect, but then there's this more direct pathway when you think about those human activities related to methane emissions. So think about the oil and gas sector. When a well is drilled, when production of oil and gas through pipelines is created, it's not just methane. You get a lot of co-pollution associated. So a couple different things are going on. You've got methane, which is being released in the air. It can help form ozone, and this is not the ozone that's way up in space protecting us, but tropospheric ozone. This is ozone that we're breathing. That ozone can irritate our lungs. It can cause asthma attack, cardiovascular events, stroke. This is well-founded, scientific evidence of this. So you've got ozone, methane contributing to ozone, and then those other pollutants. Some of them are highly hazardous that can also contribute to ozone, but actually can, if they're breathed in, represent real health risks to communities that live adjacent to those activities. And there's a lot of communities around the world that live very close, in the case of oil and gas, to those wells.
So really raising the urgency to try to address this, I think, from all fronts. So what can be done? Is this a problem that is easily solvable? I know the answer is no, but what can be done in the short term?
Yes.
What practical?
Yes. Well, I mean, what's been exciting about methane, and many of you may have been following, is there's just been a wave of energy and commitment to cut emissions. You've got commitments from, over close to 160 countries around the world committing to the global methane pledge. You've got countries that are setting up new regulations around methane. You have a new commitment among dairy producers led by Danone to cut their methane emissions. You have national oil and gas companies coming together at the last COP, again, to voluntarily, cut methane emissions. And in the oil and gas sector, some of those solutions are very readily available. I mean, it's preventing leaks, flaring, so stopping that emission from happening in the activity itself. For landfills, it's a more complicated picture. It's capturing that methane, but also, addressing all the other co-pollution that often comes with particularly poorly regulated landfills, which are a huge problem all around the world.
It sounds like the technologies, the answers
Exactly.
are there. So what's the rub? Where's the barrier?
Right. Well, so and part of why I've been so adamant about talking about the co-benefits is we have all these commitments. We now have a lot of data looking at methane, and more to come. My organization helped launch a new satellite called Methane Sat that is now orbiting and is starting to produce data on methane. There's these commitments. Okay, but emissions are going up. Oil and gas production and oil and gas exports in the United States are going up. If we're here talking about the United States because we're sitting here, the name of the game right now is accountability. And so, for example, we've done a lot of work in the Front Range of Colorado. Colorado's been a leader in trying to manage methane pollution and the co-pollutants that have been impacting people. It's a very densely populated region. They're still seeing expansion, right? They're tracking the data, they are trying to consider the health impacts, but the pressure to produce is still there. So if we're going to turn this around, we really need to expand the number of people and the sectors that are engaged in something that I think has too narrowly been just defined as this is a climate issue. This is an enormous health issue for the millions and millions of people in the case of oil and gas that live adjacent to these
So is there
wells.
opportunity there?
Yeah, I mean, I think there's enormous opportunity. Our approach has been, for example, in Mexico, again, Mexico has been a leader in this space, but production's going up. We've been bringing communities who are living at the fence line, but also the public health agencies, to talk about how do we amplify the pressure on both the producers and the government to drive that accountability. Because they're going to start being, held accountable for the commitments that they've made, but where is the political resistance in that? And so bringing in people from the health community to talk about what it means to live next to this pollution and then put quantifiable numbers behind it. So we did a national assessment of oil and gas on the public's health in the United States and estimated a whopping $77 billion in annualized healthcare costs. That's due to asthma attacks and premature death. Now that's, it's hard to prevent all of that, but that is actually making real the impact of these activities.
Well, it's an incentive, isn't it? It's
Right.
an incentive to force action because you'll have the cost savings. I imagine there's also potential, if consumers are educated, for political fallout if something's not done.
I think that's right, because
but maybe we're not aware of how exposed we are. Is
well,
this where
and-
data can play
yeah,
an important?
I think it does. And what we did in that national assessment is you could actually look at the impacts of oil and gas in an oil and gas producing state on the people in a state that aren't producing oil and gas, right? Because air pollution crosses boundaries. And so it can just make those externalities of, in this case, oil and gas production much more real, I think, to people in their everyday lives. And quite frankly, you can focus it on political actors in that space. So it's one more tool in the accountability. It's not the only tool. We're doing a lot of work in this space at EDF to hold those companies and countries accountable, including the methane stat. But it's about expanding the pie and looking at the problem holistically.
So as we exit this conversation, what message would you like everyone to take away?
I think that it's, let's think about how we can amplify some of these commitments around climate and greenhouse gas emissions and put those health impacts to it, because I think it changes the conversation. It brings new people in. The cost is always going to be high. And
The cost of treating people who are dying is very high, too.
Yeah, exactly. And so it's part of this larger discussion on the nexus of climate and health, which has been so exciting to see happen here at FP.
And something that's echoed, I think, in all the conversations that I've been in this week is trying to break down the silos, get at the problem earlier, and from a more holistic point of view. If you have many shareholders that are engaged, then you're sharing the burden, especially when it comes to capital, I think, which is so important.
Yeah, that's great.
Sarah, it was so great to see you again.
So good to see you
Thanks,
again.
everyone.
Thank you, Maggie.
Please welcome Robert Metzke, Global Head of Sustainability at Philips, for a conversation with Foreign Policy's Dr. Maisha Alam on achieving carbon neutral care.
Robert, hi and welcome.
Hi, Maisha. Thanks.
Thank you so much for being here. We were just chatting backstage about Philips, a company that's been around for more than 120 years. And one of the things as Global Head of Sustainability that you are so focused on is how to make sure that you're not just doing well, but doing good, and especially as relates to sustainability. And so let's start this conversation by getting right to the heart of the matter. How do you decarbonize the healthcare industry? And what are the biggest challenges that you face in order to get to carbon neutrality?
Well, thanks for the great question having me, Maisha. Just to put things in perspective, I think previous speakers have already very eloquently spoken about the huge impact of climate change on the healthcare systems. But let's also face the other side, right? The healthcare systems are emitting more CO2 than all airlines together on the globe, and that in a context where half of mankind does not even have access to healthcare. That's 4 billion people. At the same time, more than 10% of the global resource use goes into healthcare, with huge amounts of waste, 30 pounds or 13 kilograms per bed per day in an average hospital, can be worse. So that are just the environmental challenges of the healthcare systems today. On the social side, we see staff shortage, rising costs, burnouts, and so forth. So I think healthcare systems are under enormous pressure, and we need to understand this if we want to talk about decarbonizing healthcare. Now, maybe from the Philips side, I say sometimes jokingly, you don't need a sustainability strategy. You need a sustainable strategy. You need to make sure that you understand where the world is going and how you can contribute to that with your company. And that is exactly the nexus of doing well by doing good, aligning the company targets and strategies with the social and environmental challenges that are out there and trying to make a meaningful contribution. We have been starting in our own time on our own house also on the carbon journey, with decarbonizing our own operations over a course of a decade. I think started around 2010 or so, very systematically with carbon cost curves and what have you not. Since 2020, we operate globally carbon neutral with 100% renewable electricity and so forth. That gave us a lot of credibility with our suppliers also. If you think about, I'm sure that a lot has been spoken today about scope 3 emissions also. A lot of our emissions are in the supply chain and downstream. So some of that is, I think, an order of magnitude bigger than the emissions from our own operations. And so a couple of years back, we said to our global supply chain guys, we want you to also sign up to science-based targets. We have commitments for scope 1, 2, and 3. And we are willing to share our insights, our learnings, and really help you build these capabilities. And we want to have 50% of our 15,000 material suppliers by 2025 on science-based targets.
Yeah, and just to pick up on a couple of things you said, and I want to underscore for the audience, and I appreciate you being so frank about it, which is that the healthcare industry and the healthcare sector globally is a major polluter and an emitter. In fact, research in fact, that including my division at Foreign Policy, FP Analytics, which is the independent research division, has done, that demonstrates if it were a country, it would be the 5th largest polluter in terms of carbon emissions worldwide, which is astonishing when you think about it. And the other point that you made that's so important is specifically as relates to supply chains. It's not just about what the front care, healthcare, providers are doing or hospitals, but the entire supply chain has to be reformed. But to pick up on the last thing that you were saying, so what are those lessons learned? What are the things that you found that can be done sustainably, that can be scaled up and need to be scaled up in order for there to be industry-wide change?
Yeah, if you take the Philips perspective, then I would say it's really about understanding your carbon economics. So it's not just about making big pledges, right? A vision without the ability to execute is just an hallucination. So it's really understanding the carbon economics, putting the investments behind it. It's not just the CSO that needs to know and support this kind of stuff. It's the CFO and the CEO basically who need to get their heads around it. That's one thing. Then, of course, being systematic about this. As I said, we are really teaching our suppliers also on how to engage on these topics. We're creating financial incentives. We encourage transparency with the Carbon Disclosure Project or science-based targets. And the good thing is it seems to be working. So 47% of our supply chain have committed to science-based targets by now, which means we have one of the lowest carbon supply chains in the entire industry. And we are producing in a carbon-free environment. So that's super interesting when you go to care providers and leading hospitals around the world and say, guys, do you want to engage? How can we help you to provide better care to more people with a lower footprint? But maybe that's the next topic.
Well, it's interesting that you say that, and there was another comment that you made that really struck me, which is, from your perspective, it's not that you need a sustainability strategy, it's that you need a sustainable strategy. Now, the counterpoint to that, or a skeptic might say, well, how exactly am I supposed to balance the need for innovation with decarbonization and equity and access? And so how would you respond to that?
I would say it's a wonderful question, and I think the key word is already in there. It's innovation. Because I think innovation is the bridge that you need between providing better care to more people with a lower footprint. right? So some people speak about decoupling, others are cynical about it, but I think we live in an age where we see massive adoption of digital technology in the healthcare sector. So digitalization of healthcare is a real opportunity to make healthcare accessible and dematerialize it. To just give you one tiny example, we have been working on miniaturizing ultrasound devices. So now we have a Philips ultrasound device that has the entire technology basically in the probe in your hand. You just plug it in your phone as a screen. So if you have a 4G connection, you can use a hospital for a second opinion. We're working with the Gates Foundation to develop AI-based protocols behind that that allow basic care workers with 6 sweeps to identify high-risk pregnancies. Normally you need to train a sonographer for 7 years. So it's dematerialized, super energy efficient, much less material, and it makes healthcare really, really accessible.
Literally reducing the distance. I think that's a great example, and thank you for bringing that up. The other thing that you said just now that's really interesting is that when we think about what is it going to take to actually have industry-wide transformation, healthcare companies and health tech companies can't do it alone. And you mentioned in particular the Gates Foundation, but there are plenty of other stakeholders involved. And so my question for you is this, which is, how are you all at Philips thinking about global policy agendas, whether it's the SDGs, whether it's COP, whether it's the WHO's work on climate? How are you trying to align with those global commitments that have been made, and how are you partnering in order to bring others along?
Great question. As I said, no single partner can do this alone. We have been very engaged with the UN Global Compact. I think we signed the SDGs immediately in 2015 when they came out a long time ago already. We do annually these materiality assessments to see what are the big topics for us, and very consistently access to healthcare, decarbonization, and sustainable use of materials. So SDGs 3, 12, and 13 pop up, and they are the core of our innovation agenda, basically, right? The company purpose to improve 2.5 billion people's lives by 2030, and to provide access to healthcare to 400 million people in underserved communities. So you see it's very deeply interwoven and aligned with the SDGs, and that these frameworks provide a common language and reference points, which makes it easier to identify partners, to agree on targets, to measure these targets.
Measure impact, yeah.
Exactly, communicate about this. And I also really want to use the opportunity to congratulate the WHO on their member states also on the climate resilience framework that they've adopted at the WHA in May of this year, and the great work from Attach at the WHO.
Where we were,
Exactly, and Dr. Vanessa Carey to really drive this agenda. So, yeah.
Yeah, and Dr. Tedros was referencing that a little bit earlier, and now, the baton needs to be carried forward, right? Because it took 28 COPs before there was any focus on health, but we can't lose that momentum. Well, Robert, it's a real pleasure to have you here with us, and I appreciate you taking the time and sharing a little bit about what you're trying to do. And I know there's no such thing as going solo, so to speak, and so I hope you can bring others along as you continue that work. Thanks so much for being here.
Thanks so much for having me.
Please welcome Josh Carliner, Director of Global Partnerships at Healthcare Without Harm, Glenn Richards, Group Director of Sustainability at Bupa, and Dr. Maria Naira, Director of the Department of Environment, Climate Change, and Health at the World Health Organization, for a panel on health systems in a warming world.
Nice to see you again, and I'm really excited to, in many ways, pick up on some of the themes that I was discussing with Robert in our previous segment, and to talk a little bit about this inextricable link between health and climate, and the need to make sure that we're adapting and building resilience to both. So we have a great panel of private sector, civil society, and multilateral perspectives here, which is fantastic. And so let's dive right in. Josh, I'd like to start specifically with you, and in particular, in many ways, as Robert was touching on, and we were talking about behind the scenes, climate adaptation and climate mitigation are really two sides of the same coin. And we know that climate change is exacerbating health risks, and healthcare systems are being undermined, and they need to be made more resilient to the impacts of climate change. How do you perceive this dual challenge, and what are the kinds of investments and reforms that you think are needed in order to meet that dual challenge?
Thanks so much, Manisha. That's a good question. You know, when I think about where this dichotomy that exists in the climate world between adaptation and mitigation came from, you can kind of trace it back to the establishment of the United Nations Framework Convention on Climate Change, and then the evolution of those negotiations, where the two issues have been separated in a lot of ways. And, you know, in some ways it's important that they are, because the rich countries, the developed world, is most responsible for the emissions and needs to mitigate, while as there needs to be funding and support for low and middle income countries to adapt to the impacts of a problem they didn't cause. But at the same time, it's created this situation where we've got these two different things that are intimately interrelated that aren't dealt with together. And so, you know, if you fast forward a little bit to just a few years ago at COP26, the COP26 Health Program, which we worked with WHO and the UK COP presidency at the time to establish, created two commitments. One on mitigation in the healthcare sector, low carbon health systems, moving towards zero emissions, and the other on climate resilient health systems, which really meant adaptation. And we now have, as the previous speaker just mentioned, the Alliance for Transformative Action on Climate and Health, which WHO leads, attached, that has, I think it's 84 or 85 governments now, or almost 85 governments, that are committed to these principles and that are moving forward in addressing them. But they're still seen as separate, and they're seen as separate in the health world as well. And what we're doing at Healthcare Without Harm, and we're trying to rethink this a little bit and say, yes, these are two sides of the same coin. And we're looking at how to decarbonize healthcare while supporting healthcare to adapt, because the health sector is on both sides of that coin. It's getting hit hard with the impacts of climate change and needs to adapt and address it. And it is a major contributor to the problem, emitting 5% of net global greenhouse gas emissions. And so there's a lot of sweet spots where adaptation and mitigation measures are actually can be the same thing. And at the same time, there are some things that aren't. But if we start looking at things and defining what a climate resilient health system is, a climate resilient health system is both adaptive and it's moving towards zero emissions. And so I think that's, you know, something that we need to sort of rethink a little bit.
Yeah, I appreciate that, and it's a perfect segue to what was going to be my next question for you, Glenn, which is, you know, you're in many ways on the front line, if you will, of making sure that, you know, healthcare is not only equitable and accessible, but that it is meeting the realities of climate change, whether that's extreme heat or flooding, and being able to withstand those severe weather events. But at the same time, you know, I'm curious to know how you're confronting those challenges that climate change presents while trying to make healthcare more sustainable, environmentally sustainable through your work at Bupa.
Sure, thank you. And for those of you who don't know who Bupa is, we're a global healthcare company, and we've been looking after people's health for over 75 years. We have around 50 million customers globally. I think we very much understand that intersection between human health and the health of the planet. That is crystal clear to us in terms of the way that we service our customers. And we have to, therefore, work towards supporting people's health in this changing climate that we're facing into. And we're seeing that health systems everywhere are really struggling, right? This is the reality in which we are currently existing. So we have an ambition to really reinvent or reimagine the way that we deliver healthcare and the way that we interact with the sort of broader health system. And that kind of, that is very much geared towards creating this net zero resilient healthcare system. The way we plan to do that, the way we are doing that is obviously to decarbonize our direct operations and our value chain, which is a huge amount of work in its own right. We have ambitions to be net zero. We have the SBTI-backed targets, and we're also members of the Race to Zero. But we also recognise that we have to invest in nature for the benefit of human health, right? But there's a broader component around how do you work towards creating a healthier society. And for us, increasingly, that is about the role of prevention. And how does that come to the fore? So how do you make sure that the products and the services that we offer increasingly support that kind of preventative agenda, as well as, looking after people when they are ill? Now, we can't do that alone. I mean, this is a very common theme that you've heard from lots of people. We're proud members of the Sustainable Markets Initiative. We're working with the health system. We're working with the WHO. We're also partnering with Healthcare Without Harm. But we have also started to look outside the health sector to collaborate across sectors. And we have a built environment partnership, which helps us kind of start to think about the determinants of health and how that then is driving the way that we react to the kind of realities of particularly things like urban environments in this changing climate.
Yeah, and similarly, I would imagine rural environments too, right? And making sure that they're contextually relevant. But I appreciate your point about the different types of stakeholders that are really necessary. And Maria, this is where I'd love to bring you into the conversation. You are leading on all things climate and health, the WHO. That's a very big job. And so tell us a little bit about how you all see your role and the role of multilateral institutions, and how are you working, whether it's with member states, whether it's with other multilateral institutions or the private sector, in terms of mobilizing financing, providing technical support, and filling policy gaps where they exist.
Wow. Most of the things we do are secret, so I am not sharing here. No, I'm joking. But it's funny because this morning we were at the New York Times and it was a picture of Martin Luther King. And I remember, Marina reminded me that some years ago, I was when we were starting working on climate change and health, we were telling everyone, well, Martin Luther King, he says, his famous statement is, I had a dream. We, the global health community that WHO represented, we are a little bit more ambitious like that. We have a dream, but we have a plan as well. So, and this is the plan. The plan is everybody has a role to play. So, of course, through the SMI, we are making sure that by having WHO in that group, I hope we are not disturbing too much, but we are making sure that we put some pressure for them to do what they are doing, and we are very satisfied with what they are doing, but of course we want more. So we want to scrutinize what the public sector is doing, private sector is doing, and asking them even more and more every day, because it's a contribution that is fantastic and can be very motivating for others and can attract more from the private sector. Then, of course, we need to put around the table the ministers of health.
Yeah.
And the ministers of health, they need to recognize that if you are a minister of health, you are not just a minister of diseases treatment. You are a minister of health. So you are in charge, thank you, sir. You are in charge of making sure that your population will not be sick.
Yes.
And what we are having now is this massive primary prevention revolution that WHO wants to put in place. I mean, if we do not invest on prevention, primary prevention, because some of my colleagues, the medical doctors, will often tell me, well, but we are doing a lot of early detection of breast cancer. I said, sorry, go back to your books, because this is secondary prevention, not primary prevention. It's a critically important one, but you have already something. You want to detect something that you already have. Primary prevention means that you don't have anything, but you need to put in place what will protect you for developing. So we need to make sure that our people stop breathing horribly toxic air. Yeah. That will be a massive primary prevention. Thank you. Then, of course, so we mobilize ministers of health, but they are not the ones holding or having the capacity of taking decisions. So we put a lot of we infiltrate a lot of people in the energy sector, for instance. Yeah. And now, any conference about renewables, you will have somebody from my department talking. We infiltrate ourselves because we recognize that access to clean energy will give us such an incredible benefits for health. Then, of course, to be even more credible, we need to start to clean our own house. And then we need to reduce our own carbon footprint, so green in the health sector. But careful, because while we are here with a lot of even air conditioning, which is not needed, by the way, so on the Climate Week, we should do something about that. But thank you. But at the same time, we have more than half of the world who do not have access to electricity or any,
the energy
so
poverty.
we need to make sure that when we talk about green in the health sector, we are always explaining very well that a lot of health system needs to gain access to energy. So they are not polluting at all. They are simply suffering the consequences. For them, we want to put solar panels. Can you believe it? Something more basic than that, and it's still in Africa where they have plenty of solar energy for some reasons that I will not describe here, but if you are interested, I can elaborate. It's not, we have half of the healthcare facilities in Africa do not have access to reliable electricity. Can you believe it? But for the rest of the world, yes, we can reduce our carbon footprint. We can make our health system more sustainable, and at the same time, as Josh was saying very well, more prepared to be resilient to climate change. So it's such a win-win that I don't know what else we can say about this. Putting everybody together.
Yeah, and I appreciate so many of your points, and you really took us on a few different directions, but one in particular that strikes me that's important to underscore, and I think somebody clapped in the background, is it's not just that it's not just a matter of diseases, but even more so there is this perception that it's only about infectious diseases. And your point about air pollution is so well taken, because non-communicable diseases are significantly being impacted by climate change already, let alone in the decades to come, right? And this is something that, again, we at FP Analytics actually are just launching new research into, specifically understanding the ways in which climate change affects non-communicable diseases as well as mental health, and what that's going to mean in terms of social well-being, economic terms, and environmental terms. But the other thing that you talked about is interventions, including simple interventions that can really make a difference. And Glenn, I'd love to come back to you for a minute and just ask you a little bit about what are some of the innovations or strategies, whether they are high-tech or low-tech, that you think are most promising when it comes to making the kind of systemic change that Maria is calling for?
I think for us, the biggest kind of shift is really this prevention, so this early intervention, this ability to get in front of people, to have a conversation about how do you support their well-being, their good health, to sort of try and mitigate the risk of them suffering ill health, and the kind of and the sort of, clearly there's a, if we can do that successfully, there's a kind of triple bottom line opportunity, right? So there's improving the health outcome as a fundamental kind of initial baseline opportunity. There's reducing the burden on those health systems that are already suffering. And then there's also the opportunity to reduce carbon and the kind of the decarbonization opportunity that sits with that. I think there's a lot of stuff that we're trying to do, and it's early days, but I think we're trying to sort of really think about the way that we offer our product suite to customers. So reducing the price of the product suite to make sure we can access more people, give people more access to healthcare that keeps them healthy. Working across the private sector and public sector to put in place trials to show, or pilots to demonstrate how we can make this work in a very local context. And you know, for us, if we can make those work successfully, whether it's through the SMI or whether it's through separate partnerships, I think for us it's that's the real opportunity in terms of and they're not groundbreaking innovations. You know, these aren't sort of super new technologies. It's just about sort of working in spheres where we probably haven't done as a health system.
Well, and also to your point, there are low-cost innovations that work and low-tech innovations that work, and there's no reason not to scale those up, right? It doesn't have to be, let's overcomplicate everything. Some things are very complicated, but not everything needs to be. The other thing that, you know, going back to some comments that Maria, you were making, which is the siloing. This theme has come up over and over again. You know, the climate folks don't talk to the health folks, don't talk to the finance folks, and then you're either kind of, you know, having discussions past each other or finding that the efforts that you are, with goodwill trying to implement are falling short because of that. And so I'd love to close out this discussion by asking, Maria, to you and to Josh in particular, as we come out of UNGA79 and the Summit of the Future, and as we look to COP29 and World Health Assembly and these other critical junctures that are coming up, how do you maintain momentum when it comes to making sure that the climate and health conversations remain intertwined, that the policies developed are intersectional, and that they are financed? What is the call to action you want to issue as we go into the next season of these conferences?
In my opinion, the only way to maintain things on the interest and the headlines is to provide solutions and to provide results, and keeping and stimulating people with those results. And that's why this green in the health sector is generating a lot of motivation among the health professionals, isn't it? Because they are starting to understand very well that they have a role to play. Not that they didn't see it before, but they realize that as health professionals, not only we need to reduce our own carbon footprint, we need to lead the communities now on how to get out of this crisis, because health is the most credible and trusted, so probably we need to take action on this more than other sectors. So, and we have a sense of urgency that other sectors, they don't have. Let me be a little bit provocative. Nobody will take this out of this, so it's okay. Do you think that if the climate change crisis, when we started with the COPs and all of that, if it was targeted at a health issue, it will take 30 years of negotiations? 30 COPs?
If it was framed as a health issue.
Imagine if it was framed as a public health issue. We will disappear, the health community, if we were not taking action, or we will have results. But you cannot afford to have 30 years discussions on something that is supposed to be the biggest crisis we are facing. Imagine if it wasn't a small one. Imagine if it wasn't a small one. But if it was framed as a health issue, probably we will be on more acceleration. So now we need to use health as a motivation, very strong. The health argument that we are taking to the COPs has to be extremely strong, and we are the ones that needs to engage. And this green in the health sector is motivating a lot the health community. This is not, this is from now on irreversible. It's a question of speed, but it's irreversible.
And accelerating that. Yeah, Josh, what about you? Do you see things similarly, or do you have a different viewpoint?
A little bit different in that, I think that health was in the preamble to the Climate Convention in 1992, but the climate community didn't pay much attention to health, and they didn't frame it that way. But the health community did not pay much attention to climate until recently. What we've got, and so that, we need to take responsibility for that ourselves. But what we've got now is a growing global movement for healthcare climate action. So I mentioned ATTACH. Glenn mentioned the Race to Zero. On Monday at Clinton Global Initiative, we announced a commitment with the UN FCCC high-level climate champions to double the number of non-state actor institutions committed to decarbonizing and building resilience. That's a sign that things are growing. We have all these political commitments that are out there now. There is no going back. There is a consensus at a high level that this is an important issue, and now it comes down to implementation. It's like, how do we transform the healthcare sector so that in 10 years or 15 years, it is on a strong trajectory to net zero, to greater health equity and access to energy that is net zero energy, and how it is resilient and adaptive. What I would pose to you, the key question here that we face is that 84% of healthcare emissions come from fossil fuel combustion. Most of that's outside the hospital walls. So if the healthcare sector wants to get to net zero, it's got to advocate for a just transition away from fossil fuels. And if we're going to solve the climate crisis and be able to adapt and not end up in a 4-degree world that has huge health impacts, we also need to advocate for an end to fossil fuel use. And that transition. So that's the key issue that I think we all need to work on as the health sector in collaboration with the broader climate sector.
Yeah, and that needs to happen not just at the very high levels in forums like this, but really be reflected in community-based healthcare. So much of what you all work on and try to advocate is transformative change at the grassroots level where healthcare is delivered for the most of the world's population, right? Well, listen, unfortunately, we are out of time, and I know we've only just begun to kind of scratch the surface of these issues, but thank you so much for being here, for sharing your perspectives and your candor in terms of what it's going to take and, where we need to be forging connections and maintaining momentum. We really appreciate it. Maria, Glenn, Josh, thank you.
Thank you, Vanessa. Okay, that's it for part one. You made it through part one. We're going to take a break right now for 15 minutes. I want to thank you all for your patience and for paying attention. You're a great audience. There are some snacks outside. I have one other thing to mention. We're still waiting to let a lot of people in. So if you haven't registered for the next session, we invite you to watch it virtually. But otherwise, please come back, sit down. Oh, also, by the way, I know some folks didn't get cards that explain the program with the QR codes or magazines, even though there are several on the floor. We're going to have stacks of them outside. You can pick those up as well. We'll be back in 15 minutes.
Ladies and gentlemen, please take your seats. The program is about to resume. Ladies and gentlemen, please take your seats. The program is about to resume. Ladies and gentlemen, please take your seats. The program is about to resume. Please welcome Minister Akko Ankarberg-Johansson, Minister for Healthcare of Sweden, Commissioner Stella Kyriakides, European Commissioner for Health and Food Safety, and Foreign Policy's Anders Solinger for a conversation on universal HPV vaccination strategies.
Hello, everyone. Have you had refreshments and a break? Healthy snacks only, some protein, and we're back to chat with two great guests, Minister Akko Ankarberg-Johansson, Minister for Healthcare of Sweden, and Stella Kyriakides, European Commissioner for Health and Food Safety. We're going to talk about cervical cancer, a disease caused by HPV, human papillomavirus. It's the fourth most common form of cancer among women worldwide. One thing that we have learned over time is that women vaccinated before age 14 have 0 cases of cervical cancer. This is something we can fix. So we're going to talk about how we fix that. A 90% vaccination rate among girls by the age of 15 and a 70% screening rate and a 90% treatment rate for precancerous lesions is a path that the WHO Cervical Cancer Elimination Initiative has laid out for us. But most of these deaths that occur happen in low-income countries and middle-income countries. So we want to talk about what kind of strategies we can use to improve upon that. And Sweden has been one of several European countries to enact this. Actually, has pioneered a gender-neutral vaccination strategy and is on its way to becoming one of the first countries in the world to achieve cervical cancer elimination. Kudos. And meanwhile, very good. And meanwhile, the EC ratified the Europe Beating Cancer Plan, which supports member states' efforts to strengthen routine vaccination against HPV for both girls and boys by 2030. And it causes other cancers, by the way, HPV, not just cervical cancer. And both of these cases demonstrate a commitment to implementation. We want to pull that apart and find out what we can learn from both Akko and Stella. So thank you for joining us. So, Akko, within the next 4 years, Sweden is expected to be the first country to eliminate cervical cancer thanks to ongoing efforts to improve vaccination and screening. Congratulations. Tell us a little bit about how that's happened.
Oh, it is important for us to save lives because that is our motivation. And through working with both prevention and early detection, vaccines and screening, we could do that. Of course, we started with the girls, as you mentioned. 2010, we started with every schoolgirl in year 5. We offered cost-free, population-based vaccinations for them. And 2020, we know so much about the evidence that if we also offer these vaccines to boys in same year in school, we could eliminate cancer at women, but also other kind of HPV-related cancers. And that was a win-win situation. So we started this gender-neutral vaccinations, and we have gone further today, but maybe we stop there, because if we work with both boys and girls, we could both eliminate cervical cancer, and that's fantastic, and we could also lessen the burden of HPV-related cancers, and there are many. So it's a good thing to do.
What are the HPV-related cancers? Maybe you could educate us on that besides
You are
cervical
the physician.
cancer.
There are other HPV-related cancers which have to do with neck and head cancers and anal cancers, but I just want to pick up on, if I may, on what Akko said and what you said at the very beginning, that cervical cancer is one of the most common forms of cancer that we see in women, but it is also one of the cancers that we can prevent. And when we set out putting together Europe's Beating Cancer Plan, for the first time a holistic plan, a well-funded plan, prevention was crucial. Because when we talk about prevention, and we always say it with cancer, prevention is better than cure. But here we have an example where if we can increase the vaccination of girls and boys, we are able to actually eliminate, and Sweden is, I think, a prime example of one of the countries that has implemented vaccination strategies in a way that can actually talk about eliminating one type of cancer that is costing lives, but also affecting so many thousands of women and their families. And it's important for us to move forward with these recommendations for all the EU member states, because although the vaccine is there, it's been there for many decades, it's safe, we have access to it, there are huge inequalities in terms of the number of women and girls and boys that are vaccinated across the EU.
You know, I mentioned this to Akko earlier, and we didn't get a chance to talk about this. I have two sons in their early 20s, and both of them were vaccinated for HPV years ago. And I remember talking through this with their doctor. Why? And he's like, because that's what they're going to do. It's the right thing to do, the smart thing to do. Here in America, you know, fantastic. How can we do that in other countries? I'd love to hear if you could share a little bit more about the plan that was ratified, what your hopes are for that, and mechanisms for implementing it for other countries in the EC.
Europe's Beating Cancer Plan aims to look at the whole cancer pathway, from prevention to early detection to treatment to quality of life after having cancer, and really addressing the inequalities that exist across the EU and improving the lives of cancer patients and their families across the EU for all types of cancer. And that, I feel that we have already moved in with a number of joint actions, but there is still a long way to go. And one of the issues, and I'm glad that you brought up, first of all, congratulations on having your sons vaccinated, because it's something that we don't often see, and there is often a resistance against vaccines for girls and more for boys. We see that in the EU. So in terms of cervical cancer, we have now changed the recommendations to ensure that we vaccinate girls and boys and have 90% of girls vaccinated across the EU by 2030. But we need to address also the difficulties that we are seeing in some member states in terms of convincing them to have their girls and boys vaccinated.
And vaccine hesitancy generally. I'd be keen for you to spend a moment on that and how we can combat that. and I'm honestly not trying to make this about me, but since I introduced my sons, I actually have a special needs niece, and there was a point in time here in the States, we're long since past that, but it was several years ago when they were young, where there was a concern about thalidomide and vaccines that might be tainted, and that being a cause of this outbreak. Thankfully, that went away, but there was a lot of discussion in my household about that here in the United States. How are you handling that in the EC?
I'll just say 2 words and then hand over to Akko, because we both saw the difficulties in terms of vaccination and strategies during COVID-19 and with the vaccines. And what we did see, and this we're also seeing sometimes with vaccination for HPV, is the amount of misinformation and disinformation that is out there concerning vaccination. And we have to really address that when we're trying to promote vaccination strategies, not only for cervical cancer, but also for many childhood diseases.
And when we started to offer this cost-free vaccination for girls, 2010, some of them did say no, and that is a problem for us now. Therefore, we have a catch-up vaccination running just now, because they need a catch-up vaccination for those who didn't take it last time, and also for those girls that did take the vaccinations, because the new vaccine that we have today is more effective. So we offer every girl that was born 1994 to 99 a catch-up vaccination today. And when we do that, both prevention, vaccination to all boys and girls in year 5, and then screening, and this catch-up vaccination, then for real, we could shorten the time when we can eliminate the cervical cancer. Because if we don't have this catch-up vaccination, we will reach our goal in 2040, and that's just far away. And now we can do it maybe 2027, soon.
How about counter-information strategies? I wonder if there's any of those that you've employed. That's wonderful to offer catch-up vaccinations, but are there any mechanisms for trying to raise awareness and combat some of this vaccine skepticism?
We are working on that issue right now, because we need to talk to people and build trust. And we have had difficulties during the pandemic, so we need to get this trust back, and you could only get that if you get to talk to people. Listen to them. What is your fear? What makes you feel unsafe? Listen to them and give them the answers, because this vaccine is safe.
What lessons have you learned in Sweden and also in the EC that you think can be applied to other countries outside of the region that you think would be helpful to try and strive for this goal of eliminating cervical cancer through screenings and vaccination? I'm sure there were, the success is to be applauded and congratulated. I'm sure there were missteps along the way.
Yeah, I think 2 things. One of them is equity, because we could offer cost-free vaccination, and that is important. And we use the setting of schools. We reach to every school, girl and boy, and that's important with equity. But also that we have time-bound goals. You dare to set time-bound goals and then design your program after that. You must decide what to do, and we have done that homework.
Make a commitment. How about in the EC, Stella?
I want to pick up just a point that Akko mentioned on terms of vaccine hesitancy, because I think this is really important. One mistake that we often make is when we talk about vaccine hesitancy is we put everybody in one basket. And I totally agree with what Akko says, that we need to listen. We need to understand why people are hesitant. And not everyone is hesitant for the same reason. We need to be ready to give clear, credible information that they are able to trust, and not call everyone someone that is an anti-vaxxer, is just against vaccines. People have valid reasons why they're worried. And we need to be able to listen and to give the right answers, and try to bring people on board with vaccination strategies. These are very common problems across the EU and not only. And what we have been trying to do through Europe's Beating Cancer Plan is really put the goals forward for the EU member states, but going beyond the EU. Dealing with cancer cannot be within your own boundaries. It cannot be dealt with by looking at what is happening within the European Union. And this is why, for the first time, we've partnered Europe's Beating Cancer Plan with the US Moonshot. And we're working across and together to deal with difficult issues like pediatric cancers, like lung cancers, bringing everyone together, because only by doing that we're going to be able to tackle cancer. And ultimately, that's what we need to do.
Outstanding work. We only have a couple of minutes left. You've both been here at the UN General Assembly, running around like all of us to various meetings. I would love to hear from each of you one thing that you have found hope, and this has been a very positive conversation, by the way. We've talked about some struggles, but one thing that you found hopeful in some of the conversations and discussions that you've had here over the course of the week and some of the meetings that you've been in. Ako, maybe you could lead us off.
It's really important, the decision we will take tomorrow. We will take on a declaration on antimicrobial resistance. We need to work together against this. It's a silent epidemic that we see in the whole world, so we need to work together. And the declaration we will take tomorrow is really good.
Outstanding. Stella?
I will echo that. I will echo that. I will echo that. And although we've been working on this declaration for a while, just being here in New York and having everyone together from across the globe, and really across the globe, working towards antimicrobial resistance and talking about how we all need to work together to deal with this silent pandemic, I think for at least myself, I feel really humbled to be able to be part of this and energized, as New York is for the last few days, sharing this common goal in terms of global health care.
And walking around everywhere because there's too much traffic and being confident in health.
That's right.
I think our time is up, but I could go on for much longer about the traffic in New York at the moment.
But it's all good. Well, we are very lucky to have you all here to have these positive discussions, and we appreciate your contributions to it. We're actually going to be talking a lot more about AMR a little bit later this afternoon, and I hope you can stick around and hear some of those discussions. Very encouraged to hear some of the work coming out of that. And in fact, we did an AMR simulation with our FP Analytics research team earlier this morning, just in the room down the hall, and I think there were a lot of learnings coming out of that. And when we tackle NCDs next year, I have a feeling, my sense, so if I can add my positive vibe, that if we focus and bring everyone together, problem by problem, we'll be able to find some solutions. So I thank you for contributing to that.
Thank you, and thank you also for taking a subject like we were discussing, which is cancer and cervical cancer, and turning it around so that it's come out as positive. I think that's what people need to hear, that we can bring about change.
Wonderful. Ako, Stella, could you give them a round of applause? Thank you so much.
Next, please welcome Dr. Nwaka Laspikin, Director of Research and Innovation at the Nigerian Institute for Cancer Research and Treatment, Bob Lee, Vice President of Global Research Affairs at Memorial Sloan Kettering Cancer Center, and Dr. Daryl Sleep, Head of Global Public Health at Amgen, for a panel with Foreign Policy's Dr. Maisha Alam on tackling non-communicable diseases in low and middle-income countries.
Hi, everyone. We're going to be picking up on some of the themes that you heard a little bit about in the previous segment and really zeroing in this panel discussion on health equity when it comes to NCDs in low and middle income countries. And I'm really delighted to have with us Dr. Laspikin, Dr. Lee, and Dr. Sleep. And each of you represent a really important perspective in terms of how do we ensure that there's equity when it comes to access to care and research and innovation. Bob, I'd love to start with you. And, you know, yesterday was World Cancer Research Day, and I know that this is something that you're very passionate about and have done a ton of work around. And the fact of the matter is that cancer care has drastically advanced over the course of the last couple of decades, and there's plenty of results to show for that. But when it comes to this progress, it's obviously uneven, and especially so when it comes to low and middle income countries. And so help us understand, especially as relates to research and innovation, what explains this discrepancy and this dynamic, and how do we course correct away from it?
Thank you. So as an oncologist, I'm going to zoom in on cancer. And as an Australian oncologist practicing in New York, I'm going to give you a global perspective as well. So really global is local, and that's the solution here. Cancer is still, despite all the molecular biology, genetics, artificial intelligence, this era of technological transformation we live in right now, cancer kills 10 million lives every single year. And apart from other diseases, cancer is one that strikes fear with psychosocial ramifications throughout whole families and your social networks. So this is really a common enemy of humanity. Now, why can't we cure cancer? Because we have to do clinical trials. You have to convert all of those explosioning science into a scientific, rigorous process to convert it to life-saving therapies or prevention. So, and that process takes about 10 to 15 years to even develop a new vaccine or a new drug or a new technology. And largely because fewer than 5% of patients are accessing clinical trials, and largely relegated to elite academic cancer centers like mine, Memorial Sloan Kettering on the Upper East Side of Manhattan. But 95% of patients globally miss out on clinical trials. Now, clinical trials are considered the best care for a patient with cancer to improve beyond what we have today, but into the therapies of tomorrow. But 95% of patients miss out. There's something fundamentally wrong with that. And if we don't course correct this, we're going to be stuck with a process that is investing $80 billion a year with pharmaceutical R&D and then government investment, but fewer than 5% get the access. And you're going to be stuck with a 15-year R&D timeline. We don't have that many 15-year life cycles in our career or our lifespan. Our grandchildren will be stuck with the same. So you have to go to the 95% to change the equation, change the paradigm.
Yeah, and I love the way that you put that so clearly. And when we think about that 5% versus 95% discrepancy, I think it's really important to be bringing in perspectives and lessons from the Global South. And in particular, Namaka, I want to bring you into the conversation here. You are a leading doctor and researcher in Nigeria and across the continent with a wealth of experience. And so help everyone understand, why is there such an urgency to boost clinical research and innovation in places like Nigeria and across the African continent? You know, why is that so important in terms of the results and the operationalization of cancer care?
Yeah, thank you so much. I think Bob inadvertently gave one of the answers in his opening talk. I mean, he says that 95% of the people that don't have it. And then take, for instance, all of the genetic testing that is done, all of the precision medicine that is being birthed. How many of them actually have the African population in it? We're talking about SDG goals. We're talking about health equity. How many of them, you know, can access these drugs? How many of their genomes or genomic specimens are part of the clinical trials that exist? So there is an urgency to have the LMIC and the Global South involved in clinical trials and clinical research. And that's a no-brainer. If we want to improve our health indices globally, we must take them into account. And according to the WHO report, by 2040, 75% of the people that have cancer will be from LMICs. Again, we are driving the disparities and worsening the health equity that we are striving to change at this point in time. So I think that now more than ever is the time to start focusing on building capacity in the LMICs for clinical research, because right now it's time for us to get patients from there, get the diversity that is needed to help drug development, but also strengthen the health system in the LMICs by bringing all of these clinical trials to them.
Yeah, thank you. Thank you for that. And that's fantastic. And I think one of the key messages I'm hearing as I listen to you speak is that it is about the right thing to do, but it's also about the results, right? And what information are you drawing on to devise interventions? Are they representative of who's most affected by the problem, and therefore be able to have targeted interventions that work? And so, Daryl, I'd love to bring you into the conversation at this point, and in particular, as relates to closing the gap between research and action, or research and implementation. From your perspective, what are the kinds of collaborative partnerships that are needed in order to mobilize exactly the kind of change that Bob and Namaka are calling for?
So, you know, a company like ours that has a foundational
focus on bringing the latest innovation and the latest best science to the healthcare ecosystem to transform how patients are treated. That's great, and we completely understand and we agree. You know, less than 1% of all clinical trials are conducted on the continent of Africa, and 90% of those are in South Africa, right? So there's a real opportunity there. The one thing, though, is that, you know, we need to implement the innovation that already exists. So if you think about, you know, medicines like tamoxifen, we're going to focus maybe, because Bob's sitting next to me and is an oncologist, and consider the plight of breast cancer in low and middle income countries in the global south, as an example. So, you know, there's innovative therapies, whether it's trastuzumab, bevacizumab, rituximab, you know, fantastic, innovative, highly impactful medicines that have been developed in those 15-year cycles, but they're not being adopted and they're not being utilized systemically and systematically in the healthcare systems where they're even available, potentially even on the essential medicines list of the World Health Organization or even national medicine lists. Why is that? I think there's a big component here of, if we're going to focus on evidence generation, you know, there has to be the healthcare infrastructure and strengthening of the healthcare ecosystem where these medicines need to be adopted. We need to have mechanisms to stage shift the diagnosis into, you know, more effective screening, more effective early diagnosis, more effective intervention in early stages of disease. That takes partnerships across the entire healthcare ecosystem with, you know, people that are the healthcare institutions themselves, governments, government policy, the NGOs that are involved here, so that we can actually then bring these medicines to bear. And for sure, if we can narrow that gap and if we can actually get these medicines to the patients that need them, and then we can really tackle bringing the innovation and focusing on the precision medicine. But it's going to have to be a staged approach, in my opinion. And so, you know, we really value the partnership that we have with groups like City Cancer Challenge that are looking for local solutions, ground-up solutions, understanding the community-based problems and barriers that are in their way, so that we can actually implement the medicines that we already have.
Well, one of the recurring themes of this conversation, it's exactly where we started with you, Bob, about global and local, right? And you kind of echoed that point as well. And one of the things that you said that I think is really important for us to spend a little time on is when we think about community-led interventions. And Namaka, I'd love to bring you in on this, whether cancer or other non-communicable diseases, and there's so many that are so far reaching, and then the morbidities kind of intersect. So it's really a complex set of challenges. But in terms of, you know, locally led innovations and interventions, tell us a little bit about what are some approaches to strengthening health systems overall, and in particular primary health care systems, that you think are really important in terms of improving health outcomes in low and middle income countries.
Yeah, I think one thing that we can do is to invest a lot in implementation science research, because that is taking the evidence, as it were, and then adapting it to the local community to be able to ensure that the outcomes are the same or even better. Right now, in terms of evidence generation that was talked about, we have a lot of frameworks, we have a lot of theories that supports translation from the bench into the clinics. But do we know if those theories or frameworks would still fit and achieve the same results within our local communities? I'm involved currently in a trial. It's a clinical trial, even though it is non-pharmacologic. But we all know that cervical cancer, the best way is prevention or screening. We have models of how it would be, but as we're implementing, it's an NIH grant on focusing on HIV population. As we begin to implement some of those strategies within the communities, we've adapted quite a bit of these theories and frameworks. So perhaps it's also time to use that to strengthen the implementation science frameworks and theories as well. We need to use that to be able to contribute to the global body of information, because through those adaptations, we begin to understand that there's a dire need for contextualization. There's a dire need for us to adapt. And then at the end of the day, one of the things we want to safeguard is the fidelity. But if we keep adapting, then it brings to mind that we probably have to revamp the system.
Yeah, I appreciate that, and it makes me think back to some of the comments that you were making, Daryl, in terms of where is innovation happening, and you talked about the City Care Challenge, and that being an example. I know something that, Bob, you've been very, very focused on as well. But another context that comes to mind is Paraguay, where some really interesting work has been happening. So maybe you want to tell us a little bit about kind of what it is that you've been doing there. And if I may preview, Bob, I'm going to go to you next and ask you about how you scale that up and how do we take it from one context to another but make it locally relevant. So.
Yeah. No, thanks for the opportunity. So firstly, I'd want to echo, I think that implementation science is really where we need to go. And interventions are not just pharmaceutical or medicines, it's the intervention that makes sense. So the City Cancer Challenge program, which is a multi-stakeholder partnership that does include a philanthropic component of providing really needed medicines within the healthcare system, is a great example of what I'm talking about in terms of really a ground-up understanding of the specific needs within the healthcare system in order to be able to bring transformative medicines and transformative approaches to the community there. I think where Bob's going to go is that if we can actually conduct these types of interventions, analyze them, or do an implementation science type of evaluation of the intervention that we're bringing or the solution we're bringing, so that you can scale that everywhere, it's going to be critically important. So the component pieces in Paraguay were, from a ground up understanding that the mechanism to process the pathology specimens and having an automated digital approach to even tracking the data from the pathology specimens, the ability to actually mix chemotherapeutic agents in a safe environment that doesn't put the healthcare worker or the patient at risk, are some of the examples of foundational problems that needed to be addressed before you can start delivering trastuzumab. So you can't treat a HER2 positive patient with breast cancer if you don't have the ability to do the immunohistochemistry. So putting immunohistochemistry facilities and capabilities into that healthcare system was foundational. So there's so much that can be done, but it's not a one-size-fits-all. It's not about bringing a prepackaged solution and dumping it into that system. It's working with the community workers, the healthcare workers, the community at large on the needs. The inspiring thing about this, just finally, is that, the system and the people working within the system, there's a passion and a drive, but we move from a tolerance of the problem to an enthusiastic drive to sustain the change by relatively simple, didn't cost a fortune, didn't take a lot of heavy lifting to do this, but foundational changes. And the more we can actually learn from that and scale it through a sort of systematic approach to generating the evidence of the benefit, I think we'll be able to bring sustainable solutions across low and middle income countries.
Well, and to your point about contextually relevant, Bob, I'd love to bring you in on this, which is, I really appreciate what you said, Daryl, that it can't just be a one-size-fits-all. Somebody parachutes in, they think they've got the magic bullet, they deliver it, and they're gone. It's not how it works. It's just not how change happens. And so, Bob, you've worked in so many different contexts, and, help us, close out this discussion by focusing a little bit about how do we make sure that as part of scaling up, we are remaining geographically and culturally relevant, that we are leveraging the kind of evidence that Namaka was talking about that represents and is informed and shaped by the population that is supposed to be receiving the care.
Absolutely. So just building on Daryl's excellent point about multi-stakeholder collaboration, that's essentially the solution, the key to getting it done. It has to be a collaboration with multiple stakeholders in the ecosystem. I'm an academic, I write grants and papers and write protocols, but that's still fundamental to my work, but it's insufficient to cure cancer. We have to work with governments, we have to work with industry, we have to work with philanthropists, we have to work with business, we have to channel investment. This is a global ecosystem that requires everybody moving towards that North Star together. And there could be a myriad of ways in terms of implementation, but we all have to move in that direction. And everybody has a role to play. Spread the word, the importance of clinical trial, the importance of access for the 95%. So then you have synergy. Then you're going to see the needle moving in the global, at the global scale. So one example, the Paraguay story is really amazing. And we can do that at scale with really every country. I just came back from Abuja as invited by the Nigerian government, co-hosted with NICRAT, Namaka's institution, and also the Nigerian Sovereign Investment Authority. They're investing, their government sort of sovereign wealth fund, investing in cancer-centered establishments, and where MSK my institution is helping in terms of capacity building, channeling clinical trial investment, through biopharmaceutical industry partnerships. And my colleague Peter Kingham, who's been on the ground for more than 10 years, partnering locally, is also synergizing with this effort. And now we're starting to see that this is actually doable. We could actually set up clinical trials in Nigeria, in Lagos, in Abuja, in Ife, in many other places, hopefully the rest of Africa by extension. And we're actually discovering things we would not otherwise find in New York City. Those who are familiar with the cancer space, MSK had developed this cure for a subset of colorectal cancers with this genetic signature called MSI high or MMR deficient. Now, it's very rare. It's like in practice, it's like 2%. It's really hard. We've spent years just to catch the 20 patients to put them on trial to demonstrate this cure. But in Nigeria, it turns out 30% of colorectal cancers have this signature. So that's a swath of the population. And these are young women and men in working, productive life, suddenly got this horrible disease that's going to otherwise debilitate and kill them. You have a cure it's actually readily available. And by channeling public-private partnership and multi-stakeholder collaboration, you can eliminate 30% of colorectal cancers in that country. And let that be a shining light and as an example for the rest of the world. So these are sort of things that we otherwise would not be able to do in just New York City alone. Despite being it's a big melting pot, it's a big capital of the world and so forth, you just can't do it here. You need that global collaboration and the diversity of patients, diversity of biology, and then you come back and bring that knowledge home and support your local community. So you can't just wait until our backyard is all fixed before you go out. That's more of a colonial approach. It's not like that anymore. Those days are gone.
And it doesn't work, to your point.
It doesn't work. Yeah. You got to learn from afar and bring it back through. This is the age of technology. You bring it back, you cure your patients who are underserved in the minorities, the rural patients, really the patients who miss out in America. They need help as well. But global is local, and that's how we got to get it done.
Well, thank you for that. And wow, I love that particular example from Nigeria, and I think it's so illustrative of what you were, Namaka, emphasizing at the beginning of our conversation, why it's so important that we be investing in that research, those trials, because otherwise you're not only missing out on a patient population that needs it, but that you can learn from and make all of the interventions that much more effective. Well, thank you, Daryl, Bob, Namaka. It's a real pleasure to be with you all, and thank you for sharing your perspectives. I know this is a really difficult set of topics to discuss, and you work on them every day, but I certainly am leaving this conversation feeling hopeful, so thank you for that.
Thank you.
please welcome Dr. Stella George, Chief Medical Officer of International Health at Cigna Healthcare, Dr. Renato Oliveira y Sousa, Chief of Mental Health and Substance Use Unit at the Pan American Health Organization, James Sale, Deputy CEO of United for Global Mental Health, and our moderator, Maggie Lake, for a conversation on the next generation of mental health.
Hi, everyone. Wow, that was a fantastic conversation, such an important topic, and we are going to continue with that and move from talking about cancer to another epidemic that perhaps we don't spend as much time talking about that in venues like this, at forums like this, and that is mental health. So happy to have you all here. I'm so excited about this conversation. James, I'd like to start with you. I think we anecdotally feel and all know that there is a growing mental health crisis, and I'm sure if I asked everyone around the room to raise their hand, if you know someone in your network who's struggling or has been struggling, or in your family, all of the hands would go up, especially in this post-COVID era. But just sort of frame the issue for us that we're dealing with when it comes to mental health and where we are at this juncture.
Yeah, thanks very much. You're right. The mental health crisis, or how people refer to it in different ways, is there. And I think but the response in terms of interest and awareness is matching that. You know, we mentioned there about the pandemic accelerated some of the issues around mental health, but actually I think it also accelerated some of the awareness. When we look at structural issues around mental health, let's take financing, for example, public financing. Public financing for mental health has stagnated at around 2% of health budgets for the last 15, 20 years. That hasn't massively changed. But we know that the burden of disease has. And so whilst we hear quite a lot of support, particularly in the forums like the UN General Assembly or the World Health Assembly and other places like this as well, we're not seeing the structural side of things like financing really match that.
Which is a major problem, and again, something I think we find across sustainability and health when we're talking about that. Stella, you have clients across the corporate world at Cigna. What are you hearing from them, and how are companies being impacted by this? What are they seeing on the front lines? Because in many ways they are.
No, absolutely. I think I always say that I've been in this business for so long. There was a time when wellness was more like a checkbox item. But after COVID, now employees actually come because it's impacting not only the health of the employee, it is impacting productivity, it's impacting medical cost. And what we've also seen is how the whole concept, now it's no longer mental health. It's not watertight compartment where you say this is mental health, this is physical health. You know the whole connection between mental, social, environmental health, and even occupational health. All these impacts someone's well-being. So that's how now, even as we have evolved our conversation around the whole health or vitality, how can we talk about somebody's vitality, taking into consideration all these factors. And our employers, for instance, many of our individuals, we depend on our employees for our health insurance, like accessing health benefit or getting even access to your wellness tool. So that is in fact the central theme, I would say, of how we come into the picture. What James was talking about, that in public health there's not enough funding. That's where the private partnership through this financing model of health benefits, which has now richer implications with well-being benefits. So that's one thing. The second thing also I would highlight is the capabilities that we build. Because we have this global presence across the world, access to healthcare providers, access to technology, telehealth, and even counseling, both in person, on-site, and virtually, especially in parts of the world where we know there are challenges in having mental health resources. How can we use digital tools to support? So these are also some additional tools that providers, private partnership can help to alleviate some of the issues that we have currently.
Which is so critical. Renato, I feel like we're talking about financing, but I want to just take a step back and talk, especially when we're looking at this as a global issue, about detection and recognition. Mental health is a very big bucket. Where are we in terms of health systems to being able to identify exactly what's happening and what we mean by that?
Thank you for the question, Maggie. And that's very important because the work that we do at the Pan American Health Organization, we work directly with ministers of health, with ministries. And this is usually the type of question that they bring to us. We see how mental health is important. We realize the problem that we have here. But how can we make changes? How can we improve or create systems that in fact we don't have to address mental health issues? So the good news is that there are many solutions that can be used. Each country will define what will be the steps that they will have to accomplish, of course, according to the resources that they have. But let me also say that most of the countries don't put enough resources in mental health. So that's a very important starting area, and probably the first recommendation that we give: please increase the resources that you devote to mental health, because by increasing resources you'll be able to take the next steps. A very good next step would be to integrate mental health into the primary healthcare system. So we know that the best solution in terms of general health is to make sure that healthcare is as close as possible to the population at the community level. And for that, we create primary healthcare systems that they cannot address everything, but they are the door where people get immediate help, might be supported or referred to higher levels of care. And in that expansion of primary healthcare systems that we see in many countries today, it's fundamental that mental health is an integral part of the primary healthcare system. So these are steps that will help the country to move forward. Many countries also come to us and say, well, we have a few specialists, and the specialists that we have are not able to address all the problems that come to them. Well, so let's then support the primary healthcare system. They will be trained by and supervised by the specialists, but at the end of the training and the supervision system, you don't have anymore just one specialist, but you have a group of doctors and nurses that can address the needs of the population. These are some ways to take steps forward.
You read my mind, because I was thinking training as well, especially if this is an issue that wasn't addressed on that front line. But James, this brings up a really important point, because we know, especially post-COVID, that healthcare systems are stretched to the max. And when you're looking at funding, I can imagine that there is a conversation that takes place when you've got people coming through the door who have immediate physical ailments that may mean life or death. And if you're talking about resources, especially strange resources, how can they get past that hurdle? Or do you hear from them, I need to put my budget toward this, and then there's nothing left over for mental health? I'm sure that's why it's at 2%. How do we get past that problem?
Yeah, I've yet to have heard or met a health minister who's told me, I've got all this spare cash I don't know what to do with. Yeah, it's a real problem. And I think, what Renato was talking about there is about integrating mental health services into the primary and community level care. And it's absolutely what we need to be doing. At the moment, in many countries, that small percentage of financing, that small amount of financing, is focused on tertiary facilities, long-stay mental health facilities, mental health asylums, psychiatric hospitals, etc., where the vast majority of people do not need to be treated, where they are hotbeds of human rights abuses. In fact, I would go as far as saying that the institutionalization of many, many, many people around the world in mental health facilities is the scandal in global health that nobody's talking about. It's about integration, therefore, moving away from that, but also not just within the health sector. I think too often we think that mental health is the sole responsibility of the health ministry and therefore the sole financial burden of the health minister. Yeah. We need to think about it across the government. Mental health is a cross-societal issue, therefore it requires a cross-governmental approach as well as other actors. A few years ago, we were asked by the government of Liberia to do an investment case on their mental health policy. It was a really good, modern policy, but there was no funding for it. The budget the year before was $25,000 for the whole country. In fact, only $10,000 has been spent, so it had like a 40% execution rate as well. But we looked at that, and then when we sort of, this is a phased plan, and this is how much it would cost to fully implement that. And we said, when it comes to, it's going to be about 12 to 13% of the health budget. And going from 0 to 12 to 13%, even over a decade, was something that the minister was thinking, we can't do that. Because the halfway point of that was during the parliamentary cycle, and it was still going to cost a lot of money. But when we framed that as general government expenditure, it became around 1%. And the conversation was a way easier one to have with the Finance Ministry and with the Treasury as well, to say, look, this is around a 1% investment over that period of time, which
how
is
do you
going to
get it into that line item? Because I think we're all wondering what justifies moving it to general government expense.
So in good mental health policies, and Renato knows more about this than I do, but in good mental health policies, there will be provisions for education systems, for the penal system, for social welfare interventions. There will be provisions in there for ministries and sectors of the state which aren't just the health ministry, and that's the entry point.
That's so interesting. And Renato, I'll get your thoughts on that in a moment. But Stella, layer on that, if you can do that, for employers, is there a parallel there as opposed to thinking of it purely from a health line item to something more holistic within their organization, and can they contribute to that conversation as well? What are some policies that you've seen that are working when it comes to addressing it in that whole person aspect?
I think employers have realized that if they don't deal with this, it has a direct impact in the productivity in terms of absenteeism, presenteeism. And so there is that, and medical inflation is rising. So year over year, their medical cost goes high. So I've seen many large employers who have presence across the globe. So there is that cultural nuances also they have. I've seen them coming to us for consultative guidance. For large employers, it's not about giving them a standard benefit. It's co-creating what kind of challenge they have, what kind of budget they have, and then looking at what solution when we can put. So we did put something called an extended medical leave absence program with an employer where you identify some triggers and very proactively make sure connecting the member and the family, especially with some critical illness, connecting them to the right mental health resource early. Similarly, occupational therapy, physiotherapy, all this, connecting that care actually helped the employer reduce the overall number of months people used to be out on disability. So you could get the people back to work earlier, and plus the member is connected to all the assets they need to manage their conditions. We also have seen employers, we have different types of employers who are corporate kind, and there are employers who are more working in the field, like the UNs and the other agencies, where here we see that these employers go into the field during tough times, natural disasters, calamities. And you can imagine at that point of time their own mental health as well as dealing with people on the ground. So for this also, we partner with them to create the crisis line, because during war or natural disaster, sometimes even the brick and mortar facilities are all destroyed or non-functional. So how to create these kind of crisis line or even virtual telehealth facility where people can, and what we do is not only for those employees that only you have insurance, then you have access, we open it actually to the whole community so that people who even are not covered by the policy, they can access these kind of interventions or support.
Preventative in some ways, preventative. Renat, how important is data here? Because is this something that is, we know that there are prior stigmas. Sometimes people are reluctant. I'm sure, Stella, you see this, especially in an employee setting, to come forward and say to their organization, I'm struggling. Societally, we have a hard time saying it. What role does data play in measuring?
I mean, data is fundamental because of many reasons. And in fact, it's one of the weaknesses that we have noticed when we are following up the countries in the region of the Americas. We evaluated the plan of action that we have in the Americas, and we realized that most of the countries did not have a system to collect data on mental health. But only by having that system, I think we are able to see the magnitude of the problem, and also to be able to use that information to advocate, to show to the ones that take decision that that problem is not being tackled the right way. And even more important than that, data is fundamental for us to go into details of which populations are more vulnerable, who we are not addressing, which adaptations we might need to do into our systems to be able to address the needs of people that probably have more difficulties than others. So that's a very important work that we need to do. I think by now we have an important volume of information, knowledge, and we have created indicators that can help countries to better monitor the status of mental health of their populations. And what we need is to transform that knowledge into action, to operationalize everything that we know by now about mental health of populations.
Yeah. James, when we're talking about making the argument, it sounds like this is an investment. If you do not make this investment, there are huge costs at the end of it. How do you get in front of decision makers and make that argument? Because it is asking them to pay up front for something that could save them further down the line.
Yeah, absolutely. One of the biggest problems in health advocacy I always find is that you need to find things that will give a return within a parliamentary cycle before the next election, and it becomes difficult. But, you know, a lot of these problems start way upstream. It could be issues around legislation. You know, the mental health legislation in Sierra Leone is called the 1902 Lunacy Act. It's old British legislation that hasn't been updated. You know, it has stigma in the title of the legislation. You know, those are things where you can point out to ministers that things need to change. Do you know there's 23 countries around the world where suicidal behaviour is illegal? That you get punished if you attempt suicide, you don't get help. It means you can't pick up the phone to seek help if you're having suicidal ideation. And in some countries, that law covers children as young as 12. You know, these are things that are hard-hitting, that you can work with other civil society, that you can work with technical agencies to make the case for and to create positive, progressive pressure on policymakers. These are things that I think are obvious, and when you make the right case...
Moving, then you get the momentum that moves. Yeah. Stella, I want to give you, as we start to wrap this up, I think you see employers doing this, and this is where the partnership is so important, because they've gone from talking about it in terms of stigma to a much more positive, proactive way of framing it. I know you do surveys around these issues. What can we take away from what's happening in corporate, and can this help inform perhaps on the governmental side?
I've seen it comes from the top, the leadership buy-in and the leadership also opening up and being vulnerable. I've seen a lot. Last year we did something called the 5% pledge, where every leader, as part, like how we have our annual operating plan, every leader signed up saying 5% of our time we will be spending on mental health issues. People coming up and talking about like their own challenges, because if leaders don't talk, it has to come from top down. This has to happen. And another thing, what we have also seen is like mental health is also a common denominator for anything today. You look at it, chronic condition, there is mental health. Musculoskeletal is one of our big cost driver where we spend a lot of money. Again, mental health and musculoskeletal condition, if you don't treat the mental health and go and do an elective surgery, the outcome will not be optimum. So you have to do all this. So it's not, now there's no option. Like it's not a choice, should I go? It is important. It's important as any other, like if for cancer you're taking treatment for your cancer, equally important is taking care of the mental health, not only of the member, but also the caregivers, the family, all around. I see this like employers, in fact, the whole conversation has shifted. People want, we were talking about data challenges. Employees want us to come up with data, give them insights. And that's where the study that we do every year, this actually tracks the health and vitality trends in 11 markets year over year, what is improving. So it's not only on the health, but also age in different demography. In young people, what is impacting? It's surprising. Young people are the ones who suffer the most with loneliness and the least resilient population. The elder, so how can they go and do targeted intervention? Because today it's like multi-generation, right? We have millennials and Gen X, Gen Z, all in the workforce. So they are coming to ask this very targeted, what we need to do, what kind of campaign we should run. So I see a lot of shift on the corporate side.
I think that's so important because then with that data, we all know, we've been talking all day, then it can be the information that both of you take in the work you do to make the argument, to get the investments that are needed. And just to pick up on your point, if there are similarities across, we just heard conversations about vaccinations and cancer, and all of it is about getting there early, preventative action, making local healthcare systems more resilient to deal with this. You know, there's a synergy across all of that that can help break down the silo, and when we're talking about trying to attract capital, really make a difference if we think of it all together. So a wonderful opportunity for us to be able to have conversations across all of those problem areas on the same day, in the same place, so that we can find a way to work together. Thanks to all of you. Thank you so much.
Thank you.
Thank you.
Please welcome Dr. Jennifer Cohn, Global Access Director of the Global Antibiotic Research and Development Partnership, Dr. Yehuda Marte, Assistant Professor of Medicine at the University of Pennsylvania, and Foreign Policy's Allison Carlson for a panel on strengthening health systems in a complex world.
For joining us for so many of our sessions, and we're thrilled to build on the conversations that have been had before us to really focus on how we can address complex health needs in an interconnected and increasingly financially strained world. You know, we've talked about a number of topics today and the pressures from the environment, NCDs, mental health, and we need to understand that every individual, every human being, and their health needs are complex, and they're complex throughout their lives. And when we start thinking about what's often characterized as last mile delivery, but as someone recently told me, it's actually first mile delivery, which is, I think, an incredibly important framing and distinction, and understanding that people come first. And I'd love to talk with both of you about your experience and what insights you could share that are really addressing the complex needs and doing so in a way that are meeting people where they're at and are able to do so throughout their life course. You both have very complementary but yet distinct and differentiated experience, and so I'm thrilled to be able to dive into this topic with both of you. First, I'd like to start with you, Dr. Marte, and just do a little bit of level setting about the landscape. You've done a tremendous amount of work on breast cancer and are researching that, and have worked across sub-Saharan Africa in particular. And so I'm curious, from your perspective, in light of these increasingly complex health needs, are you seeing a shift in terms of the approach to complex care delivery, or how are you seeing that evolve?
Yeah, I think we are increasingly, so I think historically the global health community has been very focused on infectious diseases, as most of you know, and a lot of the funding had been channeled towards HIV, and so the healthcare infrastructure was really built to improve HIV care delivery, but not really thinking about the complexity of patients as a whole. And so, you know, patients who come with HIV also have issues with diabetes or cardiovascular diseases. But I think when we followed the money, the infrastructure was really built to promote HIV. And I think we've made advances there, and people are living longer. And so for me, doing breast cancer research in a global health setting is really reflective of that shift. There's really an epidemiological shift where we are seeing more and more people in low resource settings with diseases that we used to historically think about as diseases of high income countries. And so I think there is a need to pivot. And I think health systems are realizing that. I think thankfully international organizations are realizing that. So there are huge international campaigns around breast cancer care along the continuum. So not just thinking about treatment, but how do we prevent, manage, and really follow the patient throughout their diagnostic journey. There are also initiatives around cervical cancer. But the point I want to make is that I think for a long time we've thought about diseases in silos, and there's really a need to actually integrate these healthcare systems. And so the shift that we are seeing now is really a lot of people thinking about how we can leverage the things that work in HIV. So community healthcare workers were a phenomenal intervention implemented during HIV care delivery. Can we leverage that for patient education in cardiovascular disease prevention, but then also screening of breast cancer and cervical cancer patients? And I think if we can really make this change, I think that would be impactful in terms of really meeting the patients where they are. A patient cannot go to an HIV clinic. I mean, there's the time and opportunity cost. And so a patient who has several competing demands cannot go to an HIV clinic and then travel another distance to go to a breast cancer clinic and then travel some. And these are in low resource settings where patients need to take time off work. They have huge healthcare dependency needs of their families. And so I think we are starting to realize that our care really needs to be patient-centered. In order to do that effectively, the money also has to be pooled. And so we can talk a little bit about that. But I think the shift is really thinking about how we can integrate systems to address the complex needs of patients.
Thank you for that. And picking up on that and thinking about how to best meet those complex needs and the resources that are available, which are always limited, how can then we utilize what we do know about those complex needs and utilize data and information that's available from experiences, both qualitative and quantitative data, to inform that care? And so, Dr. Cohn, I'd love to turn to you. When you think about data-informed care that is addressing these complex needs, you're focused very much on AMR. How is that manifesting in your work, and how are you thinking about that utilization to more effectively address these complex needs?
Yeah, I think data is going to be really critical to address antimicrobial resistance. First, we need the data to realize what are the priorities, both in terms of pathogens as well as in terms of diseases and in terms of populations. And what we've seen is that whereas we are beginning to realize where the burden actually is, and we know it's primarily in low and middle income countries, and we know that the burden is growing rapidly. In the next 25 years, we're expecting to see almost an exponential curve of antimicrobial resistant infections and deaths. But I think what we don't know is how to deliver the kind of person-centered care yet. What I will say is we did learn how to do that in HIV, we learned how to do that in TB, and we can take some of those lessons and apply them to AMR. But we're in a fundamentally different space. I think there was like an era between the early 2000s and COVID where there was very kind of vertically focused programmatic care focused on HIV and TB. There were centralized procurement agencies, and there were large donor funds. I think we are in a fundamentally different space right now. We're in a space where, unfortunately, a lot of that kind of official development assistance is not necessarily going towards health, not necessarily going towards disease-specific areas. But at the same time, what we're seeing is strengthening of national and regional systems. And so rather than being in a place where we're going to be reliant on these centralized procurement, centralized donor agencies, we need to look at the regionally strengthened regulatory systems, procurement systems, CDCs that are now evolving, and say, how can we adjust our systems and our approaches to basically come up from there? And the last thing I'd say is not only is data important in terms of defining the priorities, which medicines are the most important to research, which medicines are the most or diagnostics are the most important to focus on for access. But even at the clinician level, and Yehuda and I are both clinicians, it's really important to have data. And in antimicrobial resistance, even if you can't have the individual diagnosis of the given patient, and that's kind of the gold standard, if you can know kind of what to expect and make a good prediction based on what the local hospital epidemiology is, you can make a pretty good guess as to what this patient might have and be able to treat the patient appropriately.
And so, Yehuda, when you hear that, and when you're thinking about these investments that are needed, that are regional or contextually relevant, how are you thinking about that? And I'm curious about how we can support more locally led, contextually relevant, and regional systems, standards, and focus without fragmenting a system. Right, because you were talking about learning lessons and being able to transfer those learnings and apply them elsewhere. And so I think that also relates to funding. And so how do we ensure that we're not then isolating ourselves, and those who do have resources and are able to leverage them more effectively aren't decentralized in a way that undermine those goals?
I think it's complex, but I think there is an opportunity for collaboration. I think, so when I think about cancer care, or just really health system infrastructure in general, we think about countries like Rwanda, who invested heavily in their health system building. And so, I mean, I think, in 20 years, they've been able to increase their life expectancy by focusing across the board on preventive health and also on maternal and infant mortality. And so I think there's really a role for governments to actually contextualize the needs of their population based on, again, data. I think, I think there are broad standards for what individual countries should be covering, but I think data should really dictate what their priorities are. I just think it cannot be, I think we're at a point in time where it cannot be very disease-focused from a centralized organization. And so, yeah, Rwanda focused on HIV and malaria and other needs as well, but thinking about how you can individually fund this is important. And, we evoke the Abuja Declaration because governments are really supposed to spend 15% of their government spending on healthcare, and that hasn't happened. But I think in countries that have gotten close to that, you can see some of that being translated into increased life expectancy and management of diseases across the board. I don't really think there should be, I don't really think global funding should really be in conflict with having national organizations that are strengthened. I think there's obviously the need for external funding, but I think governments should show that initial commitment by being able to spend a considerable amount of their GDP to really strengthen the infrastructure. And I think you can then layer upon it, non-communicable diseases, AMR, but I think it helps build data systems. It's really patient-focused in that it considers sort of the holistic approach to patient care. And so, yeah.
And so if we could dive a little bit deeper into those issues and concepts, what are a few examples of the projects and partnerships that are being mobilized that are in fact demonstrating those principles and having an impact and are part of this movement toward a more direct human-centered approach to care?
Maybe I can give a couple of examples. And when you were talking about fragmentation, I was thinking, if in this kind of new era where we're really seeing kind of the regional strengthening, and we're also unfortunately seeing a failure of kind of the R&D system to bring forward some of the tools, the medications and diagnostics we need to meet the public health needs globally, and especially in low and middle income countries. But I think we can look towards coordination, prioritization, and partnerships. And I think those are kind of through lines through some of the examples I'll give now. So I'll talk about kind of 4 things that are really important. I think in order to be able to talk about what are the most important tools we need, countries need to look at their own epidemiology, look at what are the bare minimum basket of drugs, diagnostics, vaccines, and other tools such as digital health systems that can help them address their epidemiology, and then coordinate what other countries are facing those same needs and same access barriers? And can those countries come together to form harmonized lists of priority medicines and diagnostics to improve their market strength and their ability to actually access these health products? So that would be number one. Number two, I would say we really do need to focus on access. And so one of the things that has been really great in the area of HIV and TB is there's been a lot of focus on access to medicines. And there's been very innovative things that have come about, such as voluntary licensing, use of the WHO pre-qualification program to demonstrate quality assurance and streamline regulatory approval. So what can we use now across the board, even beyond HIV and TB? But what do we have to do that's new? So for instance, we might not have a centralized procurement agency that can kind of consolidate markets. But what we can do is bring countries and other procurers together to think strategically about how they can coordinate to make sure they're getting the best prices and the best deals on the tools that they need to treat their patients. And then the last two things I will just say is that I think we need to basically prioritize what we're asking different cadres of health workers to do. Yehuda mentioned that community health workers can really help extend health systems. So yes, we need to grow the number of health workers, but we also need to be smart about task shifting and what we're asking different cadres of healthcare workers to do. And I think that's really beyond maternal care, it's beyond TB. We can do this across the board. And the last thing I'll say is we need to grow the pie in terms of financing, both on the domestic as well as the international scale.
Thank you for that and breaking that down as methodically as you did. And so, Yehuda, how would you pick up on that? And when you're thinking about that prioritization and those kinds of partnerships, I'd love to hear how you're thinking about that coalescing, and then also picking up on the point about healthcare workers and the need to expand the number, but also the capacity and the training of those frontline workers who are able to meet the needs of the patients and those that are coming to them for care. How are you thinking about those?
So I think in oncology, we are thinking about, how do we, so if you think about it, I think historically a lot of less developed countries haven't had the infrastructure built for oncology. And there are also very few training opportunities to train oncologists, pathologists within in-country. I think what we're realizing is that there's a huge gap in staffing and resource needs that cannot be met in the immediate setting. And so we're conceptually thinking about the idea of leapfrogging. Can we harness things like, I know everyone says AI, but can we harness things like telepathology to increase capacity of pathologies in low resource settings? There's also this being leveraged in radiology imaging. Can we leverage teleradiology to expand access? And so I think governments, I'm really focused on I think nationally governments should show that this is a priority. A lot of governments are now aligning their medicines and their disease focus with the WHO essential medicines list. And I think this is where an organization like the WHO EML can offer guidance on what countries should be focusing on. And so, I think newer therapeutics are shiny and exciting, but that's not what we are reaching for. We are saying for patients with very common cancers that are seen in a lot of countries, so cervical cancer, breast cancer, do we have the basic treatments to actually be able to provide comprehensive care to these patients? And I think this is where international organizations can offer some of this guidance. I definitely do think that, thinking about health worker extension is important. And so there are a lot of initiatives thinking about how we can actually not only use community healthcare workers, but primary healthcare workers in local settings to actually screen for cancers and actually pick up cancer diagnosis early. And so thinking about the individual as, migrating through the cancer care continuum. Can we diagnose cancers early so that it's easily treatable and we have more patients being cured? Can we then invest in the resources to actually manage diseases? It's actually easier to manage early stage cancer than it is to manage metastatic cancer. And so I think thinking about this in a more comprehensive way is important.
And the degree to which, by doing so and intervening early and mitigating what could be then cascading health complications, et cetera, not only are addressing the needs of the person, but also minimizing impact on a system, right, that's already stressed and it's already struggling under constrained resources. And so I think all of that is incredibly well taken. And, you know, I think when we talk about the complexity of these health needs and the evolution of them, I think it's easy to get overwhelmed and, you know, worried that there aren't going to be answers that meet these needs. And so to end on a hopeful note, you are both working like deep in these issues and also with innovations, both innovations technology-wise, but also in terms of the kinds of partnerships, working with unusual suspects who may not be the ones that we would all think would come to bear, be stakeholders in this. And so I'd love to hear from both of you, what is exciting you about the moment that we're in and where we really need to lean in so we're not just talking about these concepts that are important, but we're actually putting them into practice.
Yeah, so I think one of the things that's most exciting to me is I'm working for an organization called GuardP that is really trying to take this idea of that we're living in a new global health environment and working on antimicrobial resistance, which to me underpins pretty much all of modern medicine. If we can't treat infections, we're not going to be able to do anything else. So we need to figure this out. And I think we're working on one project that, to me, brings a lot of these things together. And it's a project to get access to a medication called cefiderocol to treat drug-resistant infections. But I think it's bigger than that one antibiotic because it basically is demonstrating how we can use licensing, early licensing, to get more manufacturing capabilities, to get a more affordable product, to bring innovations and reduce those manufacturing bottlenecks and support regional and local manufacture for critical products to meet kind of regional health needs. But it goes beyond that. It also is really looking at how a nonprofit drug development partnership like GuardP can actually begin to build the evidence necessary to use this product appropriately in the populations that need it most, and also to work with clinical trialists and implementation scientists in low and middle income countries to figure out what are the priority questions we need to be answering in order to address AMR more broadly. And last two things, it's also using some of the same market shaping approaches that we've learned about in HIV, but it's saying we're in a fundamentally different space. So what we need to do is bring the different procurement entities, countries together to figure out how can we develop regional approaches to coordinate procurement, to coordinate planning to introduce, to coordinate kind of market shaping approaches so that we can get the product quickly, but get it at an affordable price so that people, including in the public sector, can access it. And then the last thing I think we're doing that's super exciting to me is we're working with implementers and implementation scientists on the ground to really identify how do we take up a new product that is not in a vertical program. AMR is fundamentally throughout all the healthcare systems. And if we can figure this out, how to introduce new antibiotics in a safe and sustainable way, I think in some way we've cracked a little bit of the nut.
I think for me, it's really, so I was interested many years back when I was in medical school. I think a lot of people thought about global health and thought about infectious diseases right away. And I think being in an era where we're having these meetings, and I think the panel before this was really focused on cancer in low and middle income countries, is revolutionary. I really didn't think it would happen this fast. There were a lot of white papers about it. Pharmaceutical companies were a little bit dismissive about how you can really treat cancer patients in poor countries when there are competing healthcare needs. And so I think for me, just being able to see the prioritization of cancer care in low resource settings is amazing. And not just thinking about cancer care delivery, but thinking about clinical trials, and even being able to do clinical trials in these settings was unheard of like a few years ago even. And so I think the fact that there's excitement about that, but not just excitement, the fact that there's understanding that this knowledge is bi-directional. So it's not just impact, it's not just, you know, charity to low resource settings, but the fact that this is bi-directional, really creating generalizable knowledge that is applicable across patients and different demographics is really exciting. I think the second thing I'm also excited about is really the innovation. I think there's been a lot of innovation in this space to think about how we can creatively deliver care in low resource settings. And so, for instance, in Rwanda, there's a platform, a cartridge that was used to test people with multi-drug resistant TB. And now that has been adapted to test for different kinds of molecular forms of breast cancer. And I think that's really exciting because these machines are already in several countries around the world in sub-Saharan Africa. And so if you think about the lack of pathologies and lack of technicians for pathology, I think it's great to think that there are innovative ways in which we can leverage what systems already exist. And I think the last thing is really exciting is seeing the public-private partnerships. So UICC is this huge organization that that convenes a lot of bodies related to cancer care delivery. But it's managed to convene an organization called ADAM that's now trying to improve access to medicines in low resource settings. And it has a lot of members, but more importantly, there are members that are represented from ministries of health, from pharmaceutical companies, from companies that do voluntary licensing, who are able to do a lot of the marketing that really shape the landscape of HIV drugs. And so I think the fact that cancer has brought together several players and is really thinking about innovation in this space is really exciting for me.
Wonderful. Thank you for that and for your focus, your passion, your optimism, and the dedication to this work. It's incredible, and we really appreciate you sharing that with us here today. Dr. Yehuda Marti and Dr. Jennifer Cohn, thank you again.
Thank you.
Now, please welcome Christine Selig, Deputy Executive Director of the Policy, Advocacy, and Knowledge Branch at UNAIDS for a conversation with FP's Allison Carlson on lessons learned from AIDS and COVID-19.
Thank you so much, and I'm thrilled for this conversation for a few reasons. I really appreciate, you said you just ran a marathon to get here, so I appreciate
that. My kind of marathon. I ran 20 blocks. That qualifies for me.
Indeed, indeed. So it definitely deserves a round of applause, so thank you, and hopefully you've had a moment to catch your breath. And what I'm also excited about is to follow that conversation. And there were so many references to the lessons learned from HIV and AIDS and the progress that has been made over the years and how that can be applied to complex health needs now and also a more holistic, people-centered approach. And so I'm wondering, with UNAIDS and from your experience, how did you hear that and how are you reflecting on that? I know the organization just released the report Urgency of Now, right, which is recognizing the progress that has been made, the importance of it, but also recognizing there's still a ways to go. And so I'm curious about some of your thoughts about the lessons that can be applied to this more holistic, people-centered approach, but also what needs to be focused on now to have that catalytic impact and also to close that gap that still remains.
Yeah, sorry, I didn't follow the whole conversation before. I caught the last bit of it while I was catching my breath. I think there's a lot of lessons that we can learn from the AIDS response. First of all, I think we know that whatever we are facing now when it comes to pandemics or to other health crises, often health is more than a medical problem. So what we need is a whole of society approach. We need everybody. We need all of government to respond to a health crisis. And I think in HIV, we have shown how successful that is. And importantly, that includes communities. And our last report before the report on that's called AIDS at the Crossroads, our World AIDS Day report was called Putting Communities First. Sounds simple, but we know that's not happening in many, many health responses. And we have a real lesson that we can show from HIV why that is important and why putting communities and the protection of human rights, in our case with HIV, at the center of what we do. And when we say human rights, we mean the rights of everybody, including gender equality. We have heard lots and lots of data this week at the sidelines of UNGA about how far we are not doing that. And, you know, for HIV, that remains one of our issues. You know, 4,000 girls get infected with HIV every week, over 3,000 of those in Africa. And the center of that is because we haven't reached gender equality yet. So I think communities first, protecting human rights, but then also building systems that we have built over responding to HIV for a very long time that we are able to leverage for responding to other diseases and to other pandemics.
I think you make a very important point and could not agree more about gender equality and how that transcends and is related to all of these issues. And so when you think about those barriers that still exist and what needs to be eliminated in order to close that gap as it relates to sexual reproductive health and rights around the world, how are you thinking about that now in the context of the world that we're living? Also, when that, you know, the UN Secretary General has said we're sliding backwards as it relates to gender equality. So how are you thinking about that nexus, and how are you prioritizing your work and UNAIDS work in light of the world we're living in?
We always continue to, even if it's not comfortable, even if it's not the flavor of the month, we keep on saying inequalities are what drives epidemics, and gender inequality is one of those inequalities. So we have put a lot of emphasis in UNAIDS to bring other partners to the table. Tomorrow we're doing an event partly with the private sector about girls' education. Not something you immediately think of when you talk about HIV prevention, but we can show, we have the data now to show if you keep girls in secondary education, you can reduce their HIV, rate of HIV infection by almost 50% in some countries. So really thinking about what does it take to address these structural drivers of ill health is what we're putting at the center. In gender equality and gender-based violence, we know that women who are experiencing violence are much more likely to get infected with HIV. Bodily autonomy, women who can't decide about when and how and with whom to have sex, is at the center of this. So for us, that is a big part. And then obviously gender equality is a bigger part of why we have to promote human rights. We know a lot of people who continue to be infected with HIV are often in the margins of society, are the ones who have the least ability to decide how to live their lives and who to be married to and when to engage in sex, and that will continue to be our focus.
Yeah. And you mentioned education as a priority and connecting those dots.
I feel like I'm not saying anything that I was supposed to say, so I can put it down there.
I want to connect those dots really quickly and then provide an opportunity to say what you wanted to say, is just focusing on those interventions that are having the greatest impact and where that return on that investment is both direct and also cascading. And so as it relates to HIV/AIDS, but also the work that you've done, what are those investments and what are those programs that are going to have that return and be able to mitigate some of those risks? And where are you focusing that attention?
So I think we have the tools. We have all the tools to end HIV as a public health threat by 2030. We even have the countries who are showing us. We have 5 countries who have already achieved their targets for 2025, so we know what to do. What we do need is the right fiscal space to make that happen, to create the enabling environment for people to use the new medicines, to use the new tools that are on the market. We are now all very excited about some new prevention technologies, injectable PrEP, for example. But those will only work if we have the right environments, when young people can access services, when the LGBTI community in all parts of the world can access those services, and when governments make this a priority. And I think that for us is our biggest struggle at the moment, to keep on making sure that people understand we're not done yet. We have been super successful. We have 30 million people on treatment. I was here in 2001 at the first special session on HIV/AIDS. We never thought that was going to happen. But we have 10 million people who are not accessing treatment yet. And that needs our common, our joint advocacy, our joint work, but also global solidarity, which is the other piece I think would be interesting, or we need to put on the table. We keep on talking about the fact that we know what works. We say we have the right tools. We keep on talking to governments. Governments are actually investing in HIV. 60% of HIV programs around the world are paid by domestic resources, by governments themselves. But that fiscal space is reducing and reducing and reducing. And so we do need to act differently and create different fiscal space for all governments to invest in education, to invest in health, and to invest in social services. We will have 40, 50 million people living with HIV that will have to have a good quality of life, that need work, that need good health services, and so forth. And I think for us, our main message at UNGA has been, as UNAIDS, is continuously talking about how do we create that fiscal space. We can't talk about a sustainable response if we are not also talking about the other things that the Secretary General has been talking about and that are in the Pact of the Future. We need a real look at debt restructuring, and we need to create that fiscal space for countries to pay for their health and education services and other social services in their countries.
Thank you for that. And would love to build on that a little bit about the debt and restructuring and what needs to happen in this environment to really drive impact. And we were noting before, I think we can agree a lot in principle about what should be done and that we agree this is important. But from your perspective, what is the opportunity here, not only at the General Assembly further on the East Side, but also with engaging in all of those in this room, in the other meetings that you'll have this week that are policymakers, investors, and engaging or wanting to understand how to operationalize these principles. And so in your kind of call to action, what would that be? And what did you hope to communicate when you ran 20 blocks over here?
Yeah, I'm really struck by the fact that we have many governments in those countries that are most affected by HIV who want to do the right thing, but they really don't have the fiscal space. So we do need to be serious about how we make that space. We just launched 2 reports last Thursday that looked on debt relief, taxation, and creating fiscal space for health or for HIV. As long as countries paid 2.5 times of their GDP for debt repayment, or 5.5 times in the case of West and Central Africa, we can't have meaningful conversations with countries how to invest in their services. So I think that's one. I think this Summit of the Future and all of us being in New York is a real chance to talk about a different future and tapping back into that feeling of global solidarity. That's what we come from as the HIV response, right? We have done this before and we know how to do that. But it needs a real shaking up of the system, and we can't keep on talking around the things that are difficult. That also includes for governments to make the right decisions about their own tax revenue, about taxing very wealthy individuals, taxing very wealthy companies. But it also includes all of us who sit in the policy spaces where we talk about lending and, reasonable ways of lending. We know, many of us know all those things that are on the table that we often talk around, but we don't really make the right decisions about.
Yes, very well put. And the importance of really speaking directly, candidly, and forthrightly about what needs to be done to drive that impact and to move forward, as opposed to continue to have conversations about what's important and not utilize the time and that resources that are absolutely needed to be dedicated to these issues. So thank you for that. Thank you for joining us today, and we really appreciate you being here.
Thank you for having me.
Thank you.
Okay, everyone, I want to thank you for your attention. We're now going to take a very short break. If we could come back, there's some snacks out there you could munch on. We'd like you back here in your seats at 5 o'clock sharp, though, if you would. We're going to talk about pandemic preparedness and AMR, and I'm going to kick off with a discussion with the Honorable Helen Clark, former Prime Minister of New Zealand and co-chair of the IPPR. It could be a very interesting discussion. Have a great break.
Ladies and gentlemen, please take your seats. The program is about to resume. Please welcome the former Prime Minister of New Zealand and former United Nations Development Program Administrator, co-chair of the World Health Organization Independent Panel for Pandemic Preparedness and Response, Helen Clark, and Foreign Policy's Andrew Solinger, for a conversation on building a stronger pandemic response.
Good afternoon, everyone. Good afternoon, everyone. You've had a few snacks, healthy snacks, and hopefully refreshed, and you're paying attention. So I want to remind you, this is our last section of today's program. We're going to talk about pandemic preparedness, AMR, and if you're patient, there will be a drinks reception in an hour and a half or so, sponsored by our partners JSK and Guard P. So please do stick around for that. Very excited to have this conversation with the Honourable Helen Clark, former Prime Minister of New Zealand. And it's very important and poignant what we're talking about. We're talking about building a strong pandemic response, something that needs some attention. Of course, the pandemic exposed vulnerabilities globally and heightened awareness for greater preparedness for global emergencies. And we have failed to advance a multi-stakeholder response to prepare for that. And we're putting billions of lives at risk and a lot of treasure as well. So we need to work on that immediately, especially because pandemic threats are intensifying. Climate, we were talking about that earlier, is part of the culprit, as is AMR resistance. So AMR problems. So we have to really be more proactive and have a sustained effort by policymakers and funders and the industry and practitioners to mitigate risks. So we're going to talk about that today with Helen, who, in addition to all of the great things that she's done, she was co-chair of the Independent Panel for Pandemic Preparedness and Response, the IPPR. So we have the great person here to talk about these issues with. So thank you so much for joining us. So in 2021, you and the great Ellen Johnson Sirleaf, along with others, the IPPPR, laid out a series of concrete recommendations to transform health systems to mitigate risks from future pandemics. That was 3 years ago. Earlier this year, you issued a new report called No Time to Gamble, Taking Stock of Leaders' Progress. How's progress, Helen?
Well, I think you look at what's been happening over MPOX and you'd have to conclude that we haven't learned a lot. Same old issues, vaccine inequity, lack of readiness, etc. So what's kind of gone wrong? Firstly, with pandemics, you go through a cycle of utter panic, which is where we were in 2020, and certainly probably well into 2021 for many countries. And then you go into a cycle of neglect. And then I think there's been a bit of a tendency, particularly in the high-income countries, to think that pandemics are things that happen somewhere else. COVID was one that got away and engulfed the world, but MPOX, well, it's kind of over there, so the reaction doesn't come as quickly as it might. Now, so where do we stand now? In some ways, worse off, because COVID stripped out countries of all income levels of fiscal space, right? We all dug in the high-income countries very deep into our pockets. We don't have a lot of fiscal space. We're trying to make some of it up again. And for many of the low-income countries, low-middle-income countries, the fiscal effects are quite devastating, and just simply increase your indebtedness and economic fragility. And the other thing that's worse is that the longer COVID went on, the more the vaccine skeptics and the science deniers got a bit of a hold. Yeah. So going into another pandemic, would we as readily get vaccine uptake as we did? I have to pose that question. It also raises issues about whether we can get as widespread childhood vaccinations as we used to getting if science distrust grows. So there's those background things. Now, in other areas, we called for dedicated preparedness finance and surge finance. No sign of the surge finance, by the way. You need a mechanism where you can scale up really quickly, and it's thought to the tune of about $100 billion when a pandemic strikes. But go back the step before that. It was estimated you need about $10.5 billion every year in solidarity funding to support low and middle income countries to be really prepared. Now, the pandemic fund was set up. It hasn't gathered $10.5 billion a year. It's gathered somewhat under $3 billion once, I think, and it's vastly oversubscribed every time it took that a call. So the money isn't there. Our panel and, of course, very keen group of advocates around global public investment say the model's wrong, that when we go to finance global public goods like pandemic preparedness, we need a different formula altogether, from each according to their means, each according to their needs, where everybody pays into vertical fund for this purpose, but then you get out according to your needs. Well, that hasn't happened. Okay, secondly, on new legal measures, we do have new international health regulations, and they do improve things a bit. But let's see how quickly member states get to implement them. They come into effect in May next year, and countries really need to put a lot of effort in now to making sure they've got the capacity to do the new regs. The pandemic accord negotiations in Geneva, well, they go on, and they go on. I don't think they're going to agree this year. They could. It's all political will. But, cycle of panic and neglect, leaders' attention is somewhere else. So then come to the issue of WHO financing, which we raised. Woefully financed. As is commonly said, the WHO has about as big a budget as a large New York City hospital. Well, that's not much for Global Health Organization. No. And WHO is in the most brutal round of internal cuts at the moment, because it's strapped for cash, and it shouldn't be strapped for cash. We need to support it to do its job. The last point I'll make is on the countermeasures, medical countermeasures in the event that the pandemic strikes. You've got to have the diagnostics, you've got to have the therapeutics, you've got to have the vaccines, and of course the oxygen, the PPE, and the rest of it. And these are really the issues that the global negotiations found are over, because our high-income countries really do protect IP and pharmaceutical companies, not to put too clear a point on it. In a pandemic, we've got to share knowledge. We're talking about an existential threat, but we're not geared up for that. TRIPS waivers. Has there ever been a TRIPS waiver? There was never one for HIV. We've got no way of really getting these things moving fast when we face a common threat.
So let's talk about that a little bit. But if I'm hearing you correctly, so other than a few things, we're doing great. Is that what you're saying? That's very discouraging, and I know that's why you're in all seriousness. That's why you are beating the drum. People, we need to wake up. So thank you for doing that. But let's dig into a few of these things. In the wake of COVID, that is part of what we need to do about sharing IP and sharing knowledge is giving rapid access to pathogens, viruses and bacteria. That becomes essential for developing vaccines and treatments for effective responses. But now countries are concerned. Why should I share my pathogens with you? You're not going to share any of your IP, and we're not going to get any funding or any material benefits. So we're at this loggerheads. So the sharing of outbreak surveillance information, as well as the sharing of actual samples and genetic sequences, have been a major topic in reforms. What has been the progress? What can we do? What challenges are in the way?
Well, this is the sticking point, right? What's called the PABS blockage in negotiations, pathogen access and benefit sharing. And you're right. Low and middle income countries are saying, look, you people are demanding access to the pathogen information and sequencing and so on, but then you go away and develop these responses to it with a vaccine or therapeutics or whatever, and you don't share it. So why should we give it to you? You should pay for that access. And that's based on, of course, a precedent, I think, in the Nagoya Protocol and the Biodiversity Convention. And then the rich countries saying, oh, no, we're not going to pay you for it. You should put it into the pool. And the lower middle-income countries are saying, yeah, but you wanted the pool, but you don't want to help us. So we've gone round and round in circles on this, and that's what the talks will founder on unless there's political will to move somewhere on it.
And how do we break that? There's got to be some type of middle ground.
Well, okay, so if high-income countries dig in on not paying for the access, and low-income countries say, well, tough, that the impasse continues. But are there creative ways around it? Is there a large, global common good fund which would say that in the event of the worst happening, there can be access bought? But there's actually a more fundamental issue that we raise with 45 seconds to go.
That clock's broken. Don't pay attention to it.
And that is, we need a different ecosystem. We are so dependent at the moment on by and large, the large pharmaceutical companies of the North doing things. Yes, there are big players in the global South. India has big players with vaccines, therapeutics. Brazil has big. China has quite big. So you still need more centres of research and development in the global South, if I can use that term, which are linked to a manufacturing capacity, which are then linked to finance for rapid scale-up if the worst happens. And the WHO is onto something with that establishment of the mRNA hub-and-spoke arrangement, which should, our report said, be expanded to other technologies. But the outfits that are trying to get into the R&D in the South are finding it very hard to get access to the money to really make it a going concern. And the thing about pandemic readiness is it's like the dog that didn't bark. Look, for a lot of the world, the dog hadn't barked on a pandemic since the 1918 flu pandemic. Right? So there's kind of a whole cycle of panic and neglect. But if we don't learn the lessons from what happened with COVID, we will be blindsided again. And you're right, the zoonotic spillover events, these zoonotic diseases are coming at us thick and fast, and you need just that whatever unique trigger of combination of factors which will send something global rather than confine it to a discrete geographical area.
I completely agree with you on that. I told you I wanted to end on a positive note, but let's not do that. At the Summit of the Future, the Pact for the Future was supposed to include emergency platforms designed to rapidly coordinate global responses to pandemics and climate disasters. This just came out. Did that happen, or were they stripped out?
Stripped out. Look, there's let's not go into the long history of the Pact for the Future, but, you know, the Secretary-General and his team, they've done quite a thorough job leading up to this. They appointed a high-level panel, which Ellen Johnson-Sirleaf was also co-chair of that, and that panel made some good recommendations about the future agenda. The SG's teams put out a series of briefs, including around emergency platform and complex shocks. And then that was to feed into the negotiations for the Pact for the Future, and eventually it got stripped out. Now, in my humble opinion, he should have just done it, right? I mean, once you ask, then you leave it to member states to play with the negotiations. Yeah. They strip it out, and we've now got a pretty meaningless, really, reference in the Pact for the Future to we will consider how we will approach responding to complex shocks. Well, great. I think what we can say about the Pact for the Future overall is it touches on a lot of very important areas, but it touches on them. It provides hooks if you've got determined diplomats in countries who want to pick up these hooks and say we're going to put some, well, this tree and make it a Christmas tree with a dressing. But at the moment, it's a bit of a skeleton.
Well, I'll add a little positive note, and the positive note is that Helen Clark is sounding the alarm on that and not letting these guys run away without taking responsibility for that. So let's keep doing that. Thank you for joining us to give you your frank opinions on that. We appreciate it.
Please welcome Dr. Lauren Charles, Chief Data Scientist and Group Lead of the Applied Artificial Intelligence Systems Group at Pacific Northwest National Laboratory, Dr. Louise Gresham, Senior Fellow in Global Health Security at Pax Sapiens, and Dr. Ben Oppenheim, Senior Director at Ginkgo Bioworks, Inc., for a panel discussion with Foreign Policy's Allison Carlson on data, AI, and the next pandemic.
Great. That's quite an act to follow.
It is.
And quite a lot to pick up on, especially what she was just mentioning about the hooks. And Helen Clark said it so compellingly and profoundly, like picking up those hooks. And I think recognizing that there is still work to be done and different ways to leverage expertise and technology to understand where we're at, the nature of the threat, communicate that clearly, and what can and needs to be done now to address it and to really strengthen preparedness going forward. So much of the programming earlier today was focused on this intersection of climate and health. And we know that as our environment is changing, there are increasing stressors on the environment that are changing the pathogens. And pathogens are evolving from higher temperatures and a number of these stressors, both for humans and animals as well. And something that doesn't get much airtime, I think, in this landscape is the potential for zoonotic transfer and the risk that that presents. And so I'd really like to shine a light on that as part of this conversation, and also hear from all of you and the work that you're doing, the expertise that you have, and the organizations that you're coming from and how you're thinking about that. And as I was saying, I don't think it's well known. And so, Dr. Gresham, I'd like to start with you in terms of characterizing that risk landscape, and particularly what is the threat from zoonotic transfer?
I think you would have a good sense of the landscape if you even looked at the public health emergencies of international concern that we've dealt with, 2 times for Ebola, 2 times for Mpox. And you know, the FEICs have legal criteria, although we have seen that there are some logistic, political, and financial maybe swaying of a time period of a declaration of a FEIC. But even that uncertainty, I think, is a good word to describe this landscape of zoonotic threat. this deep entrenched uncertainty from clinicians who have to deal with Mpox patients, for example, and for local, national, and global public health practitioners. And I think it's also probably this uncertainty in the psyche of people when they try to understand zoonotic threat. But we understand the goals. The goals are to reduce this successive process of interactions between humans and animals that lead to a spillover or a jumping of a virus. And we have the same goals to reduce the numbers of cases of disease, not to just have this picture of zoonotic threat from a FPHE perspective, but certainly to have it from the perspective that if you can reduce the number of cases, you're going to reduce the likelihood of mutations. Therefore, you will not have a pathogen of greater virulence or one that is not effective with a vaccine. And the other goal is to be able to discern the difference between a natural occurrence of a spillover and a intentional biologic threat. This is very important to be able to distinguish that. It's harder to do when you have thousands and hundreds of thousands and millions of cases to see if something is occurring out of season, has higher fatality rate, has a different dose response pattern. But let me end with the landscape in a positive way, unlike the moderator before us, saying something positive in that we do know a lot about the settings for spillover. We know live markets, wet markets. We know that we have zoos and fairs and abattoirs, the slaughterhouses, and the cattle ranches and the mink farms that have led to disease. And yet we think through regulation that could be moderated quite well, even with this pressure and uncertainty from the climate change perspective. And so these solutions, I think we have to be much more creative, like on mink farms. The mink farmers developed their own vaccine and implemented it. They did not want CDC on their property. And so there are ways to reduce this uncertainty and threat, and I'm happy to be joined by experts of Ben and Lauren on this. Thank you.
Thank you. To pick up on two things that you said to address the uncertainty, which I think is contributing to fear and a lack of knowledge and worry about this threat, but shining a light on it and understanding from increased surveillance, data science, and establishing an evidence base can help us discern, right, what that risk landscape looks like, where there are hot spots, where threats are emerging, and from what, to your earlier point, so that we can have greater clarity to then understand and discern what those possible responses, but also preparedness entails. And so, Dr. Charles, I'd like to turn to you when you're thinking about that expanded surveillance and ways to develop that evidence base. How are you working on that? And I also loved the optimism. That was the other thing I wanted to point out about the tools that are being developed to understand that risk threat and the threat landscape more holistically.
So I think to answer that question, it's best to take a step back and really just think about where does disease come from? How does a disease outbreak? So to have disease, you need a susceptible host, like a human, a favorable environment, a infectious agent. That could be in the case of a disease vector, like a mosquito, or a reservoir host, or a different type of host, like an animal in the case of zoonotic diseases. Without all three of these present, disease cannot occur. So we think about in nature, disease is naturally there. It keeps ecosystem balance. Pathogens are within their hosts and in the environment for years without causing problems. But how does disease outbreak? We think about the favorable conditions needed to have this disease outbreak. And we think about changes to host behavior, human behavior, susceptibility, changes to the environment, as we talked about earlier today, climate change and things like that, as well as changes in the pathogen itself. And potentially it's disease vector or it's reservoir host. So once you have more disease individuals than expected, disease outbreaks. So when I think about this and I apply it to my research, I see that to be able to really have early warning, prediction, understanding of what's going on before a human gets sick, we need to take this holistic One Health approach where we're not just waiting till a human's sick, but we're looking at these other factors. We're looking at animals, which could be your pets or the wildlife in your backyard. We're looking at humans and societal factors that drive disease transmission. And we're looking at even food and agriculture and how that plays a role within our landscape. And by looking at it in this holistic way, we realize that there are so many signals out there that we can use to actually detect health threats. And so by applying greater surveillance, increasing the amount and the types of data that we are analyzing, we are able to actually get a handle on this. And luckily, this day and age, we have computational power capable, as well as artificial intelligence, which enables us to pull in all these types of data and actually make this approach plausible and in a way we can do it.
Great, thank you. And picking up on that then, Dr. Oppenheim, with you, how are you then utilizing the evidence and forecasting to fill some of those gaps in the data and the evidence, but also using that then to try to mitigate this panic and neglect cycle that Helen Clark was referencing as well?
Yeah, that panic and neglect cycle is really, fundamental, and it's driven not just by, amnesia and the kind of pressure to move on to the next policy problem of the day. It's driven fundamentally by a lack of data. We're asking policymakers to make enormous investments in surveillance systems and response capacity and preparedness, and we're asking them to make those investments under conditions of deep uncertainty about when they'll be used and what they'll be used for, what impact they'll have. So a lot of the work that we do, some of the work that we do, focuses on trying to really build out the evidence base on the risk that faces us, specifically through quantifying the likelihood of seeing pandemics like COVID-19, like pandemic influenza, estimating the frequency and the severity of those events. We actually have a paper coming out in Disease Control Priorities led by my colleague Nita Madhav. It's very long, but I recommend it highly. And it sets out some estimates that we think can guide both the level of investment and the urgency of investment. And to give just one brief example, oftentimes when we talk about COVID, we talk about it as a once-in-a-century pandemic or once-in-a-century phenomenon. And it sort of makes sense, right? It happened about 100 years after 1918, but that is just a statistical quirk, right? It could have happened in any given year. All the conditions are always present, some being amplified, some being depressed. Our estimates, and you don't have to take our word for it, there are other scholars using different techniques who land in a pretty similar place. Our estimates suggest about a 50% chance of a pandemic the size of COVID-19 occurring within the next 25 years. So a coin toss, basically. And that coin is being tossed every day, every month, every year. And so from our perspective, the urgency is to take that coin toss seriously and to make data-driven investments, both, again, about the scale of financing needed to support surveillance and response, and, again, the urgency to make those investments now.
I really love the way you characterized that and broke it down, and I think it's a little bit of myth busting, right? Because I do think that is incredibly prevalent, that there is this notion out there that it was once in 100 years, and we have plenty of time before we have to worry about something like that again. And I love the way that you characterized that. And when you think about kind of mitigating this panic neglect cycle, and also the need for developing the evidence base, but also sharing that evidence base, how are you thinking about that in terms of enabling and fostering greater transparency in what you're finding? I know you referenced the paper, which absolutely we should all read, but also I imagine that there is some reticence about sharing some of the data and outbreaks where they occur for fear of backlash or other potential consequences, real or perceived, from that. And so
I'm curious how you are all thinking about that in your work and how to foster that greater transparency and systematic sharing of the evidence so that more people can be informed and that data can inform the work that they're doing for preparedness.
Well, I would give an example of regional disease surveillance. And there are regional disease surveillance networks in the Middle East, Southeast Asia. A new one that was launched in February by Dame Harries at the UK Health Security is the Pan-European Network for Disease Control. And I say that, not that I don't understand that all disease starts locally, but when it comes to sharing and creating value, we find it very important that people are able to, in a context, whether it's a cultural context, a financial context, or even capabilities context, for people to be able to come together and say, perhaps we could have a joint protocol for an investigation of H1N1 so that you don't have to cull 1 million chickens. Maybe you only have to cull 50. Because we're sharing this protocol, same data, standardized data, norms, and people are acting very much at the same time across the system and are able to visualize the data. And that data to them, Allison, has so much more value than data that they don't understand. And I say they, as an epidemiologist, I mean me. I have been in that place where I am given so much data, so many predictions, but if I don't have the context or the value, will I really be able to make a good decision, a rigorous decision, or maybe one that would cost me my job decision?
Yeah. Do you want to pick up on that? In addition to that, I feel that very strongly, and we have found that through bringing stakeholders together, not just the data providers, but also scientists that are doing the research and that are going to be using the data, to sit down all together and really think about, what is the importance of data sharing? Why are we doing this? What are the obstacles we have to overcome, as well as what data do you even have? I have seen so many misunderstanding of what type of data others have. It's crazy, but once you realize this is what we have, this is what we're willing to share as well. You don't have to share everything. There are certain things that can help others for just basic understanding of a signal that can be very helpful, as well as just thinking about what types of data would be useful to that person, what type of analysis would be useful to that organization, and then what does a collaboration look like? Really starting with those basic things helps to build up that trust in that sort of collaborative spirit to actually enable these things to occur.
So I think this question of trust is really fundamental. And so in our work, we build and run operational disease surveillance programs with a number of countries around the world. And many of these are located at travel hubs, where lots of humans moving very quickly through space, and their potential kind of foci for outbreaks and for disease to spread. We think, as a matter of principle, it's deeply important for the countries to own their data, own their samples. That's how we want to operate. And we want to create positive incentives for them to share that information on a routinized basis, right? Not after an emergency strikes, but on a daily basis, to have these nodes communicate with each other and bilaterally or multilaterally share disease surveillance data to build up that level of trust so that when things become politically tense or difficult, the mechanisms for communication and collaboration are there. They don't have to be built from scratch when it's hardest to build.
Can you elaborate on that a little bit more? And I'm really curious about changing incentive structures. And so when you're thinking about that, how would you approach that, and how can that be shifted and adjusted to really incentivize that greater sharing?
It's a really good question. So we're grappling with this, I'll say, actively every day. And maybe I can answer it in two ways. I think at the kind of macro level, countries are rightly worried that they will be punished for doing the right thing and reporting an outbreak or reporting a pathogen. They'll be subject to travel or trade bans. And we think that we need to fundamentally invert the incentive structure to report outbreaks. There are financial mechanisms that have been under debate to do this. For example, like contingent capital, it could be released if a country reports a pathogen. And I think the problem that solves is not so much the money problem, like countries obviously need capital to respond to outbreaks. It solves the trust problem that maybe they'll actually get it done. And so if the international community of other countries have confidence that an outbreak will be contained, then maybe the country that's doing the reporting, that's stepping up and doing the right thing, won't be subjected to those kind of punitive measures. So that's one kind of lever we can pull. The other one that I mentioned earlier is really just establishing kind of routinized data sharing, where countries kind of see operational value in their own public health programs on a daily basis, like as they get used to sharing and used to seeing incremental value. Where it will build up muscle memory about how to do this well.
I'd love to pick up on that and spend the last few minutes building on that idea of new and innovative models, changing incentive structures, and how we can utilize the expertise to then inform decision makers, policy makers, and really get beyond what have heretofore been some of those sticking points or controversies or limitations in that. And so, also in the spirit of ending on a positive note, would love to hear from each of you in the last few minutes that we have, what is exciting you about that and what you foresee as being transformational in getting beyond some of those sticking points and thinking about the approach to this work a little bit differently. So, Lauren, I'll turn to you.
Sure.
And then
Louise. At the national lab where I work, Pacific Northwest National Lab, we have an approach called AI-driven One Health Security, where One Health Security really means that the health and security of humans, animals, the environment, plants, are all interconnected. And with this sort of approach, we have been able to really play upon, one, expanding our surveillance, our situational awareness beyond just humans. Extremely important. It opens up so many avenues for earlier detection of disease. Two, the ability to apply these AI technologies to advance and speed up early warning, mitigation, detection, all of these different components. And lastly, the technology is there for secure and restricted data sharing, as well as pulling in real-time surveillance data. But the issue has been that collaboration and trust, which is this big issue that we're talking about. And that is one we really need to work on, because without it, it's just not going to happen.
Louise?
Sure. I'm here representing Pax Sapiens, which is funded by the Arsenault Family Foundation. And Marcel committed during President Biden's COVID summit in 2021 funds for pandemic prevention. And I mention that because this type of support for me personally is key as we translate these ideas that we have so passionately. And for us, we are very much supporting a high-level panel with politically influential people to look at pandemic risk, to look at the drivers, to understand the science more, so that these AI complex predictive models make more sense to people. The second thing I would like to see, Allison, the last one, is I would like to see this cycle broken where countries have to wait for global data to take action. I think their ability to do that at the local country level is key, and I believe that can happen. Thank you.
Thank you, Louise. And Ben, I'll finish with you. How do you see that being broken, and how do you see a more regionally led, locally led approach?
Well, I think some of the experiments that we're involved in and we're kind of seeing develop around the world with complex networks of countries and disease surveillance programs sharing are incredibly inspiring. Like it's really good work. And it opens up the possibility of layered surveillance systems that are data-driven, are responsive. There's a lot to build to bring this to life, but there's a lot to build on in terms of progress to date. And I want to pick up as well on something Louise mentioned about the potential to really advance the science. So COVID was a horrendous catastrophe. It also catalyzed in a very deep way a kind of a level of scientific commitment and dialogue that we haven't really seen in this field before. So I am incredibly optimistic about our potential to begin to aggregate, systematize, to look across really disparate fields that all kind of understand components of that disease transmission process that can ignite pandemics, to add that up and to build something for our community more like analogous to what the IPCC has done for climate, to chart a path forward, to aggregate evidence, to keep score, to tell us how we're doing, mitigating the drivers and the push factors that are impelling pandemics. So I'm many miles to go, but I'm highly optimistic we can get there together.
Yes, and also the energy, the passion that all of you demonstrate. I was mentioning to all of you, joining you in the green room, as you all came together, you could feel all the excitement about the opportunity before us and the way that you can harness each other's insights and experience to really make progress and move this forward in ways that heretofore have not. So thank you for sharing that wisdom and insight with us, and again for being here.
Thank you for having us.
Please welcome Dr. Noor Shamas, AMR Survivors Task Force member at the World Health Organization, and Foreign Policy's Dr. Maisha Alam, for a conversation on the human side of AMR.
To different models of 50 airlines to make price.
Oh, I stranger.
Dr. Shamas, Noor.
Try it again. Hello.
I don't know, you can speak. Sorry, everyone, we're just getting the audio sorted.
I'll send you a piece.
I'm on.
There's no reason to this.
Let me walk to the mic.
How are you doing?
Fine. It's just, it's an adaptation.
Obviously, we're in the. And I have to. I don't, but. Well, I'll see you tomorrow. I'll see you tomorrow anyway. Oh, that's right. We've got the hot. I'm going to.
I'm sure we can project, but I don't want to.
Oh, I think it's
starting
now.
Yeah.
Okay,
Yeah.
great. Sorry, and thank you for bearing with us.
Well, Dr. Shamas, Noor, it's a real pleasure to have you here for what is a really important conversation and the first part of a two-parter on antimicrobial resistance. And in particular, we are sitting down to talk about your experience both personally and professionally when it comes to the lived reality of AMR. So your professional journey on AMR has been deeply influenced by your personal experience as a caregiver for your mother who survived an AMR infection. Tell us a little bit about your mother's battle with AMR and how that shaped your professional trajectory.
Yeah, thank you for having me and for having my mom's story. She's very excited to share her story always. She says hello. She's fine now, relatively. But so basically, I'm from Lebanon, and my experience in infectious diseases started a long time ago. Growing up in a very nice part of Beirut with access to everything that I could think of because I am relatively privileged. So at the time that in 2018 my mom got sick, she had to have emergency back surgery, and I was actually in the US at the time at a conference, an infectious disease conference, learning about all the exciting new research on resistant organisms. So she had her back surgery while I was away. A couple of months later, she tells me her back pain is getting worse, and then she started developing urinary tract infections. At the time, she wasn't diagnosed early enough because people thought she had a back problem. But then it turns out she had a kidney infection and the bacteremia, which is bacteria in the blood. She was septic. She started taking antibiotics that we had to pay for out of pocket, of course. She had to take IV antibiotics at home that we had to pay for, home health care. And then she started getting recurrent infections. That's when she started asking me questions that I had never thought of before, like, why is it that I am getting these recurrent infections? Is this a sexually transmitted disease? Why do I have to see an ID specialist, an infectious disease specialist? Because it's sort of stigmatizing. I don't want to have this on my profile, in my patient profile. So I learned a lot of things from her eyes as a patient, because earlier I used to think, right, this is just an extended spectrum, this is just an organism, it's not that big of a resistant organism, it's not a big deal. But then you think about, all right, this patient can't touch their family members. This patient can't, they have to take IV antibiotics. We don't have access to these antibiotics. So I used to carry these antibiotics with me from abroad to Lebanon because you can't buy them in Lebanon. Diagnostics. We're very lucky because we went to a good hospital that we can pay for, but most people don't have access to diagnostics. Sure. So that's been a really big part. And I just came from Turkey because I had to take my mom and my brother to Turkey because in Lebanon things are really bad. So we had to take the antibiotics with us just in case she has an infection there. And then now they're back to Lebanon, which is another issue, but yeah.
So, I mean, I'm listening to you speak, and first of all, I just want to say thank you for sharing your mother's story. And, I know that you are an advocate, a champion, a physician, and you're passionate about this, but I imagine it's not easy to talk about it because you had to live through that and support her, and none of us likes to see our loved ones suffering. So first of all, thank you for sharing your experience and really humanizing what might otherwise seem just a scientific or statistical problem, but in fact doesn't just affect the patients who are undergoing that experience, but their caregivers, their family members, and their communities. And through that experience, you were mobilized to act and to use your voice and your expertise. And so I want to talk to you a little bit about that. You've led AMS programs in various healthcare settings around the world. And one of the questions I wanted to ask you are, what are some of the most significant challenges that you've encountered when working in very diverse environments, and how can the international community better address those specific challenges in order to really move the ball forward on AMR?
Yeah, thank you. Actually, that's I'm very lucky because I did work in different environments, and I think the common denominator or not failure of stewardship programs, but difficulties, is that people think of stewardship as like its own new program. But stewardship is effectively using resources appropriately. So that's a patient safety thing. It's not a new program that's, we have to implement a new antimicrobial stewardship program. You need to find ways to embed stewardship into current processes. And that's what people have trouble with, as all of you in your work probably face. There's a little bit of ego when it comes to new programs. There's a little bit of ownership issues. And those are the kinds of things that stewardship leaders need to kind of break down so that you can implement proper stewardship. So finding your way into the hearts of the patient safety specialists and the surgeons and the leadership and logistics that buy the medications and make sure that they're available, or making sure that diagnostics are purchased rather than just thinking, let's just buy antibiotics, use them empirically, and instead invest in getting really good diagnostics. So those are some of the things. And I think another big part is education. The US is another ball game, but in the most parts of the world, there's not really a lot of stewardship education, meaning there's not training on the undergraduate level. If you talk to most medical nurses, pharmacists, physicians, no one really knows what AMR is. No one really knows that infection control is their responsibility. You can't just say, okay, it's a nursing issue. And even how many stewardship trained people have you seen? There's not really a lot of stewardship focused training, specialization. And lastly, what I think is a really big problem, especially in the low middle income countries, is implementation science-based research. Yes, of course, we care about new medications, but what we want to know is, from my perspective, is should I use the $500 that I have today on, let's say, switching IV to oral antibiotics, or should I use it on buying, the most expensive new medication for these 2 patients? So what is the most interesting thing for me?
Yeah, no, and those are really important and complex considerations, and we're almost out of time, but I just want to end with one last question, which is, we're here on the eve of the AMR high-level meeting tomorrow, and the next segment will focus on AMR as well. What is it, from your lived experience of being an advocate and a caregiver, that you want policymakers to understand in terms of AMR survivorship?
I think first thing is to include AMR survivors in meetings and boardrooms, and because sometimes what you think really is most needed isn't really, we don't have a lot of evidence sometimes, and you need to include patients with lived experiences. WHO, we worked on a document called, it's entitled The Meaningful Engagement of AMR Survivors, so please look at that document. The other thing is, in healthcare infrastructure, of course, it requires strengthening. You need to work on universal healthcare coverage in order to implement proper stewardship, but also finding ways to bridge the gap between policymakers that are outside of health that look at, for example, conflict, for example, making available proper roads for people to access healthcare. So these are, of course, yes, of course, we need to work on AMR, but embedding AMR into other policies, AMR-sensitive interventions, I think, is something we really care about.
Yeah, thank you. I appreciate that last point and that kind of whole ecosystem approach, if you will. Well, those are some great and practicable recommendations, and I appreciate them very much, not just from your perspective, but because I think they will definitely inform and shape the next segment that we're about to have as we dig in deeper on AMR. But Noor, thank you so much for joining us, for sharing your and your mother's story, and for taking the time to raise awareness and educate everybody. Thank you.
Thank you.
Please welcome Dr. Monica Balasegram, Executive Director of the Global Antibiotic R&D Partnership, Dr. Sunya Swaminathan, Chairperson of the M.S. Swaminathan Research Foundation, and Dame Emma Walmsley, Chief Executive Officer of GSK, for a panel discussion on innovative solutions for equitable and sustainable antibiotic access.
Hello again. As I mentioned in the previous segment, which you were all watching both in person and online, I can hardly think of a more important and timely issue to be discussing than AMR, especially as we're here on the eve of the high-level meeting that's taking place. And we're really fortunate to have such a distinguished set of panelists representing industry, science, civil society here, and multilateral institutions as well. We're going to dive right in, and there's a lot we want to cover. And Monica, if you don't mind, I'm going to start with you and ask you a question that might, for some people, seem counterintuitive, but is actually really important, which is, we hear so much about the overuse, oversubscription of antibiotics and how that can be a driver of AMR. But GARD-P is trying to expand access to them. Why? Explain why that's important and what role preventative measures have when we talk about, advancing the challenge of AMR.
So thank you very much. Just thank you all for coming here today. Just to introduce myself, I'm the Executive Director of GARD-P, but my background really is as an emergency physician. And over the course of my career, I've been very lucky to work in very different aspects, ranging from clinical care to drug development, working in public-private partnerships. But a major driver for me has always been about access, and I think we need to see access as really a fundamental dimension of giving healthcare, whether it's access to healthcare, access to essential health tools, etc. And I think it shouldn't be any different when we talk about antimicrobial resistance. We don't see in our organization stewardship and access as conflicting issues. We see them as integrated issues. You can't really think about stewardship without access, and you can't really think about access without how you want to use these drugs responsibly. It's worth remembering that, you know, we've seen with all the data that's come out recently that this is a growing problem. We have, you know, millions of deaths, whether they're direct or attributable, related to AMR. This is going to be increasing by 2050. But one of the striking figures that came out from the Lancet study of last week was that you can look at 50 million deaths being averted by improving access to antibiotics. And that's a remarkable figure, because that's the low-hanging fruit we have to think about. For us, we have to think about improving access to old, established antibiotics that are also on the essential medicines list. But we are dealing with a very dynamic field. You know, bugs evolve and change. Who knows what's going to be happening over the next 25 years? And we need to ensure that we also replenish the pipeline. And this is where the R&D dimension also becomes important. So I hope that's answered the question.
Yeah, no, it's great, and it's a great place to start, and I think gives us a lot to build on. And you know, you talked a little bit about R&D, and closely related to that is, of course, data to inform the science and data to inform the policy decisions. And Somi, I'd love to go to you next and ask you specifically about this, which is, how does the lack of reliable data to inform policy decisions affect the ability to combat AMR, and what steps should multilateral institutions and their partners be taking in order to improve the quality and availability of AMR data globally?
Thank you. So obviously without good data, it's really very difficult to make policy at any level, global or national or subnational levels. And so I think there are many aspects to AMR data. And of course, the WHO has the GLASS database, which is basically countries depositing data on antimicrobial resistance, especially from a set of priority pathogens. Now, this is mostly a tertiary hospital type of data. It's still patchy, and it's not representative. So it reflects the extreme, you know, patients who are hospitalized and may have a lot of nosocomial infections and so on. So clearly we need much more data. We need data from the community as to what the prevalence of resistance, because that's when the treatment guidelines will have to change, because depending on what kind of resistance you're seeing in the population, obviously then you would recommend different antibiotics to be used. And I agree with what Monica was saying, that in large parts of the world, it's lack of access to antibiotics that's killing people. And in the future, of course, it's projected that more and more people will die because the antibiotics are not working anymore. But even the ones we have are not being effectively used. So I think broader data also from environmental surveillance, and this is something now we've seen during COVID, and also has been used for polio for a long time, but now there's a much greater availability of genomic labs, of sequencing facilities. These were all set up during COVID. We should be using those now to collect more data on very specific on the mutations, and in fact that might be an easier, more rapid, maybe even more cost-effective way, since the infrastructure is in place to collect data. And then finally, we need data also from agriculture, fisheries, veterinary, and so on, because we know that, you know, this is all interconnected, and that's when we talk about the One Health. And so I think a very practical application of One Health is with AMR, where at the country level, there must be a good way of sharing data between these different silos and sectors. And that will help policy making, because in India, I remember we were able to regulate the use of certain antibiotics for animals based on this type of data sharing.
I think that's such an important point, and over the course of today's discussions, this issue of siloing has come up, and I love how you put that, because it's such a practical way of understanding the interventions can't possibly be targeted if you're not really understanding the connections between those sectors and data that is, you know, collected across them to inform strategy making. Dame Emma, it's great to have you with us, and I want to talk to you a little bit about the role of the private sector when it comes to addressing the AMR challenge and picking up on the threads that we've just heard a little bit about. And so, there are a multitude of challenges related to AMR that the pharmaceutical industry has a role in addressing. Everything from the environment to availability of medicines to preventing the overuse of antibiotics. So, from your perspective, can you share some specific initiatives that GSK is implementing when it comes to trying to address these various challenges and to do so in a way that's both holistic but also specific to the challenge?
Yeah, of course. I mean, first of all, I would say it's wonderful to be here on this globally critical topic, the eve of some very important discussions tomorrow, and I could not agree more with my colleagues' comments today that the access challenge is multifaceted and too often is shorthanded for industry as being a question only of affordable pricing, and it's very, very far from that. Of course, it has to be sustainable pricing, but it's really multifaceted and integrated with stewardship and innovation as well. For us, these are the questions to engage in are innovation, first of all, continuing to fund a pipeline of new, needed, effective antibiotics, prevention, and that is about, frankly, preventing some of these diseases before they even start, including with the deployment of vaccines, which are one of our greatest possible tools against AMR. Of course, the variety of aspects of stewardship that we all know and that is so complex in limiting innovation for the sector because of the incentives that are seen not to be in place. Multi-dimensional challenges of access, including education and obviously the right diagnostics, so the right antibiotics are being used with the right kind of compliance with their usage. And all of these things need to work together, which is exactly why we want to work across all of them. We start by leading with our science. We are a global leader in infectious diseases, and I'm incredibly proud that at GSK we do continue to invest, building on 70 years of experience very strongly in one of the largest AMR relevant pipelines in the industry. We've got more than 30 projects, in fact, across medicines and vaccines, and 13 of them facing into WHO prioritised pathogens. And because we know we have to keep accelerating progress, and that's also put us in a position to be number one in the AMR benchmarks innovation category as well, but we've also engaged with multiple partnerships, whether that be our funding of the Fleming Initiative or indeed the very exciting new engagement with GARD-P as well, because we do believe that innovation comes in partnership, and it's about maximising our usage of the latest technology to advance our chances of success here.
Sure, yeah, and just to pick up on a couple of the things that you said, and these are all just such important elements of the whole picture. And as I'm listening to you speak, much of what you said also builds on what Noor was talking about in the previous segment. But one piece that is key is the mobilization of resources, and I want to touch on this a little bit. And Manika, just to come back to you, funding is a perennial challenge, and we understand that in order for this to work, there's going to have to be innovative financing as part of the solution. So tell us a little bit about, what are those funding models and innovative financing mechanisms that you think could sustainably support the development of and distribution of new antibiotics, exactly of the kind that Dame Emma was touching on?
Yeah, I'm not a policy guy, so I'm not going to pretend to kind of wax lyrical about this, but I would say that you need to see this more as an investment rather than just funding. I mean, the implication of saying we need push and pull funding is not untrue, it's true, but when you put it that way, it looks like a burden. And I do think that this is a fantastic investment in our future on multiple different levels. That would take me too long to explain. I think it's important that people understand that obviously people know that R&D is a risky and expensive business, But from our perspective as a public-private partnership, we have to interface with many different types of actors. For instance, we work with small biotech companies, as an example, who are often, the spearhead of innovation. We work with mid and large-sized companies with different types of partnerships, including around access. And of course, Emma's mentioned, the recent partnership with GSK, but just to shout out, we also have an access partnership with Shionogi as well, which is an extremely challenging and very interesting project we're working together with. But we are also working with other companies that are more involved in manufacturing and supply and distribution. And you have to be thinking about how are these companies going to be staying in the game in order to not just do the research and development, but also ensures a long-term, sustainable, quality-assured supply of these antibiotics, and ensuring also that they are affordable. So this is a big challenge, and this is why people have started talking about the need to have these innovative financing mechanisms and push-pull mechanisms. I'm obviously conflicted when I say that this isn't enough. I won't pretend I'm not, but it isn't, because this, as I mentioned before, this is something that we have to see as a long-term. We're working in a very dynamic field. These bugs are mutating faster and on a very different dimension to how we live our lives. I think that's part of the challenge, and we just don't appreciate that difference between the bacteria and us. And I think that's also another reason why we have to think about this differently, that dynamic, very dynamic element, which means that it's a long-term but constant innovation. You're not going to get solutions that, magic bullets that will fix the problem indefinitely. So I think this is something that we just have to accept and think about in the long term. I will finish by saying that we also then have to invest in access, and obviously looking at access in a responsible way. But this is where in the past I think we've often missed that part of the equation. And I've looked at it in my own experience of how we've introduced antibiotics in different parts of the world in my career in the last 25 years, and also scenarios where we never did introduce those antibiotics. And I think we have to solve those two different challenges.
Well, and speaking of those multifaceted challenges, a couple of the things that you touched on build directly off of what Dame Emma was talking about. So I want to go back to you for a minute, and especially as relates to sustainability. As you said, GSK has been around for a very long time, and you all have been doing this for a very long time, but also the role of partnerships. You can't do it alone. So tell us a little bit about how those two pieces come together in terms of your work on AMR.
Well, as I said, if you're thinking about the question of access, that's certainly not something we can do alone. By the way, we say the purpose of our company is to combine science, tech and talent to get ahead of disease, including AMR, together. It starts with prevention. So that means vaccines, and we have huge programs of partnership with Gavi, for example, the Vaccines Alliance, to increase access to vaccines. We've been doing that for over 2 decades, and the right kind of stewardship. We talk about robust surveillance and the sort of data that we need to have, and we have a big program in India at the moment to be able to look at the infection index, which we're then able to partner with healthcare professionals to give them visibility at a truly local level in terms of the susceptibility to different antibiotics, and offer a service to them. It's also deeply about distribution on the ground and in the front line. I was just on a visit to Kenya very recently and was talking to Kelvin, who was a young expert in a community centre in Mukuru, and he was extremely clear that on the subject of supply, reliable supply, there's a big difference between how you secure reliable supply for the new innovations, starting with, are they registered? Do you get the kind of demand, even at the beginning that can be low demand, and how do you get the right kind of diagnostics around a brand new antibiotic? But even when you start with generic antibiotics, there's often a real issue with demand forecasting that can then lead to stockouts that then drives inappropriate use. And you still get 10% or so of antibiotics that are frankly counterfeit. So there's a whole variety of different ways where we have to, partner in the front line and very locally, because you have different challenges in different countries, particularly across the global south.
Yeah, and picking up on that last point, and I know we're almost out of time, but I want to ask one last question and would love to hear from all of you on it very quickly, but starting with you, which is that, as we're here on the eve of the high-level meeting tomorrow, what would you like to see in terms of specific commitments from world leaders to turn goals into actionable steps? And what are the strategic shifts that are needed, having, in your experience, Soumya, worked in such difficult and diverse settings where this challenge is already a lived reality?
So I think if we all recognize that antimicrobial resistance is a huge problem now and even bigger one for the future, and in fact, from the science perspective, we know what we need to do. We have to work on developing new antibiotics and vaccines for sure. But even currently, we're not doing the things that we are supposed to be doing. So for example, it would be great to see commitments on the agriculture side, for example, to reduce the use of, or eliminate the use of antibiotics as prophylactics. There's enough evidence that helps to spread AMR in humans. Like to see commitments, from different sectors around also training, capacity building of healthcare workers, improving supply chains, and the things that Dame Emma was talking about. And then finally, I think the world can come together. Governments invested huge amounts during COVID to rapidly develop vaccines, and it was possible to do. So I think with the current state of science and technology globally today, if private-public partnerships happen and governments invest, then I think things do happen. So I would hope that they pick up something like TB, for example, which needs to be solved. And I know that GSK is working both on vaccines and treatments for new drugs for TB, and say we can solve TB. Why should 1.5 million people be dying of TB? And it's not drug-resistant TB, just normal TB. Why, in this day and age, should we accept that? And if we can come together and solve that problem, it's a very good way and a huge motivating factor for us to say we can do this for other bugs as well.
Yeah, I really appreciate both your sense of urgency, but that optimistic tone. So in the last final seconds, Monica and then Dame Emma, anything you want to add in terms of that final call to action with the meeting happening tomorrow?
I don't think I've got anything to add. I just want to see something concrete happen. I mean, at the end of the day, governments are responsible for their countries. They have to prioritize this. They need to finance their national action plans. But it does help if they work together. And I know it's not a fashionable thing to say anymore, but the solidarity really does matter. It just saves everyone so much more time and effort.
Nearly 40 million people are going to die by 2050 unless we wake up and do something about this. It is extremely serious. It is a real and present danger, and we have an opportunity, and I want to be optimistic like others tomorrow. We're looking for three things. First of all, that we do incentivize R&D and innovation, because at the moment resistance is outpacing R&D, and that does mean some new policies, pull policies that governments should introduce, not only to stimulate investment, including in biotech, but also critically avoid perverse incentives for prescription. Secondly, we've got to recognise the value of vaccines and stop the misinformation that is rapidly accelerating, frankly, even in theory, the richest countries in the world. And that is a serious, serious problem, because there is no greater return on investment than stopping disease before it starts. And lastly, it is an agenda that we need to work on together, whether that's across countries, across civil society, across academia, and also I'm really pleased to see the recognition of the private sector in this, because we do have a role to play, and we're extremely committed, including to catalyse that impact tomorrow, so that we can get ahead of AMR together.
Well, thank you to Monica, Soumya, and Dame Emma. I know that each of you are involved in these negotiations and discussions, and I hope that it goes well and that we can see the kinds of results and change that you've all, emphasized is really needed for saving people's lives and having a healthier planet. So thank you for all that you're doing.
Thank you.
Please welcome Dr. Ernst Coopers, Vice President of Research and Distinguished University Professor at Nanyang Technological University, Singapore, and member of Global Leaders Group on Antimicrobial Resistance, and Sunita Narayan, Director General of the Center for Science and Environment, India, and member of the Global Leaders Group on Antimicrobial Resistance, for a conversation with Foreign Policy's Andrew Solinger on the global fight against AMR.
The global fight against AMR. So I'm with two people who are ready for action also. And I thought that was a very interesting panel, very worthwhile discussion. And we're going to wrap it up here with two members of the AMR Global Leaders Group. Very pleased to have you both here. Ernst Kuipers, Sunita Narayan, thank you for joining us.
Thank you, Andrew.
Maybe we could start off. Let's just go to the top. Tell us about the Global Leaders Group. How do I apply? How do I get into this group? What do you do? What is the mission? And tell us a little bit about it.
Wait, should I?
Yeah, please.
Please.
Yes, please do.
So it was a group put together, and I can see other members of the group as well in the room. Group put together essentially to try and keep the conversation on AMR going. And somebody like me, I'm not normally part of such groups. I'm an environmentalist, and I'm a bit of a kick-ass environmentalist. So, I was invited in because the issue of environment and the issue of agriculture, food-producing animals, was not understood as well. And so we were an interesting group, and led by Mia Mottley, the Prime Minister of Barbados. She's a force to reckon with.
She sure is.
And that was very good leadership, because it brought different communities. We had people from the industry, people, Ernst was there from government, helping to show how government could move, how the Netherlands had done so much, and what could be the policy prescription. So it's a good group.
So we have a kick-ass environmentalist, self-described, but we also have, until very recently, health minister from the Netherlands, and a gastroenterologist. So a kick-ass gastroenterologist? Is that like redundant? I don't know.
All that.
Sorry.
Who actually started his original research as a graduate student very long time ago in a lab, inducing resistance in bacteria, because we needed multiple resistant in the lab.
Haven't you come full circle? Yeah.
So, I mean, if you look at it from a clinical perspective or a governmental perspective, usually what we do is we focus, and we rather focus on what we call large topic, and we heard them this afternoon also, like oncology or mental health or whatever. And then antimicrobial resistance for many people also in clinical medicine is like nitty-gritty. It's case history. But it's not. It's of huge importance, and just to give the numbers, so you know them well. Latest report, WHO, very recently, the estimate is that at this time already, annually there are approximately 1.2 million people dying every year as a direct result of antimicrobial resistance, and indirectly another 5 million. And the estimate is that this will increase in the coming 2 decades with at least 70%, if not double.
Dame Emma just brought out a figure of 40 million people. I mean, we're talking real numbers here.
Real numbers.
So let's talk about mobilizing resources, fostering public-private partnerships, pushing for innovation. First, I wanted to talk a little bit about the importance of the One Health approach. Yes. Maybe, Sunita, you could tell us a little bit about that, what it is, why it matters.
So, Andrew, that's really where the big question today is. We know that antimicrobials are necessary for human beings. They're miracle medicine. It's the silent pandemic that we keep talking about, that we are losing the power of those medicines, and we're not getting new ones on the table. And that's the whole question about antimicrobial and the challenge of it. Now, one of the other pathways why you have resistance growing is because of the huge quantum of antibiotics, antimicrobials, which is used in growing food, in producing animals that are used for food, and
the waste that comes out of the environmental, the manufacturing sector, the hospitals, which is all adding to this sort of the bugs that are in the
And it's actually more than the antimicrobials that we use as humans.
Absolutely. And so the threefold agenda for One Health, if I could just quickly wrap that up, is one, conservation. There is a group of antimicrobials that are critical for humans. We need to conserve it. Think about it like a biodiversity agenda. We need to conserve it. Now, we need to make sure that those are not used in animals. And that is part of the political declaration draft. There is wording on that. And I think that's very important recognition. Conserve that group. Don't use it for animals so that we can make sure that it is available for future generations. It's like a common resource. It's a trust that we have to the next generation. The second is the issue of prevention in animals, because, you know, the fact, and I'm talking from my perspective, my country's perspective. I come from a country which can't afford to first pollute and clean up. And that's actually also your country's problem, but you won't recognize it. But but I certainly...
Have you walked around New York lately?
But certainly in our part of the world, we cannot afford to pollute and then clean up, which really means how do we prevent the use of antimicrobials in animals? And that's where the question of how we grow our animals. If you have intensive agriculture, highly stocked animals in unhygienic conditions, you have to use antibiotics. So the whole question then becomes animal, intensive food farming systems.
Yeah.
And the last question, and that's really the prevention agenda, is the more you look at clean water, food, the less you have to use antimicrobials.
So that's the agenda.
Please.
Briefly add to that. So the One Health concept seems to be very new. But if you look at our ancestors for tens of thousands of years, they have very, very well known that they were an intricate part which was fully dependent on the full environment, not just the animals and the plants, but everything. So One Health is basically not a modern invention, but it's a very, very ancient invention. And now this goes much further than just our animal husbandry and our livestock and our agriculture. If I just can give one example, we have very good evidence now from different parts of the world, China, Europe, the North America, that, for instance, the increase in our ambient temperatures as a result of climate change actually by itself already increases antimicrobial resistance. The estimates are like 1 degree increase leads to a 14% extra antimicrobial resistance, just as one. Now, also the fact that antimicrobials are basically everywhere, in your soil, in your surface water, etc., is a good example of that. And with that, and also with all the other effects of climate change, it's really a full circle.
Right. You referenced, Sunita, earlier, the political document that has come out. Maybe we could talk a little bit about that. What was in that political document?
So, from my perspective,
and what wasn't in it?
Yeah, from my perspective, and it's really about, so we wanted more. And, but I think it's the political document, you know the UN system, it's all about consensus and the lowest common denominator and, all the rest of it. But so two major issues were there that the GLG had asked for, 3 issues. We wanted the world to set targets, firstly, because targets are important ways of holding governments accountable. So the first target, which is in the political document, is about a 10% reduction in mortality from AMR by 2030. That's in the document. Now, that can be quantified. It can be used to look at where governments stand, what can be done more. How do you fund the government so that their national action plans can happen? But the other 2 targets, which were targets, so there was a target on critically important antimicrobials should not be used in animals. That is now this, UNE's watered down.
Unis, that's a language,
watered down sort of, it's there. So if you scratch and you look, and somebody like me, it's there. But it doesn't add up to saying, do it, which is what I would have liked to see. And the third is that we had asked for a 30 to 50% reduction in the use of antimicrobials in the food and the agriculture system. So a tough target, okay? It's there, but it's turned into a language that says meaningful reduction. So I can live with it because I have to, but I obviously would like to see much more happening, because at the end, Andrew, and I'll leave, the last point is, this is not just about AMR, this is also about climate change. Because remember, agriculture is the core of the climate change crisis. And so if you're talking about biodiversity, you're talking about climate change, you're talking about AMR, they actually come together from the perspective of the food we eat and how we grow it.
I can add to that.
Please,
because a report is one thing, and I think the importance of a report, even if the wording is not optimal, is that it puts it on the agenda and at the forefront again and again. And that's what we do. And we have to do that also together, and also realize that many of the individual topics can actually be achieved by creating awareness and taking action at any individual level. If I just give you the examples of what we achieved in the Netherlands, we heard about a lot of use in animal husbandry, in livestock. So with continuous measures over a decade, we achieved an 80% reduction of antimicrobial use in our farms without any effect on the economics of the farm. So the traditional story which you will hear is, oh, this cannot be done, and otherwise it can be done. And actually, the farmers will not lose money, but they gain money. They don't have to spend it on, etc. So there was one thing. If I just look at humans, for instance, here in the US, I learned again last week, if you look at antimicrobial use and exposure to antimicrobials during pregnancy and for newborns, for neonates, we know already that if they are not very, very targeted, they actually do a lot of harm. There is a lot of evidence nowadays that use of antimicrobials in newborns may significantly increase the risk for a whole range of conditions, including obesity, which is a modern disease. Now, in the Netherlands, the use of antimicrobials with very strict guidelines during pregnancy is nowadays 20%. 20% of the women receive antimicrobials during pregnancy. Here in the US, it's approximately 70%, 70. So I dare to post the statement that a marked proportion of that additional 50% is actually doing harm and no good. So once we know that, and it's just not for saying this is what the Netherlands do, no, we can share. There are many other ways where other countries are doing very well.
So let's dig into that a little bit.
Yeah.
Increasingly, countries are issuing national plans on AMR. What can we do to ensure that that's happening across countries, and how can we popularize that
so we can,
and help with that implementation and share learnings?
Yeah. So for one, I mean, on a clinical level, but also on farming and in agriculture, etc., there are many, many connections, not just on a governmental level, but also for long. I've been a member of, for instance, here an American Gastroenterology Association. This is what people do. Like you meet and you exchange and you develop international guidelines, not just in medicine, but in other areas as well. You can monitor that. You can follow up on that. You can also, as a government, stimulate that. Another one is a discussion, and we had the same in the Global Leaders Group, is look, and we heard the discussion here already, our models, like for antimicrobials, is like for many other things, are based on payment for use. But what we want to do here is actually pay for the innovation and then not use it. Well, that sounds like a strange model, but if you think of it, there are many things in life where you pay for preventing and not using it. Your fire extinguisher at home. In the Netherlands, we pay a lot for our waterworks, and they are based on the potential risk which might occur once every 10,000 years. And we happily pay for it and maintain it. So the discussion was we need similar payment systems for antimicrobials.
Sunita.
So you at the earlier panel were desperately looking for a good news story.
Yeah.
I want to end with one.
Could we do that? That would be great.
So I want to end with that. So in India, we have a huge dairy industry. I mean, we are the world's largest milk producer, but we produce it very interestingly from smallholder cattle owners. So 1 cattle, 2 cattle, 3 cattle. We have this very large cooperative system called the mother dairy. And they became very conscious of the fact that they needed to control the use of antimicrobials.
The mother dairy.
Okay, the mother dairy. It's called the mother dairy, which is this large confederation. And very interestingly, and this is where it's about the prevention, they really went back to what is called ethnomedicine. So medicine that, would be produced in the home almost, the grandmother's recipes for medicines, made at home. But the trick of it is to get farmers to understand, to catch the disease before it actually happens, and to be able to give that medicine, and also to make sure that they understand that you can do so much to prevent the disease from happening. And as a result of it, they have seen the use of antibiotics across this massive milk-producing system they have to come down to less than 20% of what they were using. And the most interesting part of it is, and that's what, at the end of the day, it has to come home to you. You have to do this. And in this case, the farmers did it, interestingly, for something that you and I would never we would do antibiotics, reduce it, it's bad for humanity. And the reason they did it is because when they used to give antibiotics to their cows, they didn't produce milk, which would make good yogurt. And in India, yogurt is used more than even milk. And it's a very simple thing. It kills the bacteria.
Yeah.
Yogurt is about bacteria. Okay? So they actually took to this, one, because it reduced the cost of buying antibiotics, two, because they saw something that they got which was good. So I think for all of us, the story is really how do you bring it home so that it works for us and we understand that it's in our power to actually make the difference.
That is a good news story. Thank you for sharing that. I like that one very much. We're over time right now, but I just wanted to say I don't think I could be a Global Leaders Group member, and I don't know who's doing the picking, but they're choosing very nicely.
Propose you to become one.
I would say that another good news story is that we're very grateful that the two of you are serving on our behalves, because that made a lot of sense, and I'm really encouraged by it. Our global leaders, thank you so much on AMR.
Thank you.
I'm sorry for being over time.
No, you were great. You were great. That was great. Wonderful. We'll see you in a minute. We're wrapping up. Give me 1 second here, though. We've got a few things that we want to do here. So first of all, I want to thank everyone who's here in the room for a really great day of programming. These sessions, one after the other. I'm so impressed by the incredible work that the FP team has put into bringing these folks in. It really was a tremendous program. So how about a round of applause for those folks? I also want to thank our partners and our presenting partner, GSK. That was so great to hear from Dame Emma. Great discussion. We're also going to have a reception in a little bit, courtesy of GSK and Guard P. But I also want to thank all of our other supporting partners who made this possible. Amgen, AstraZeneca, Bupa, Cigna Healthcare, City Cancer Challenge, Environmental Defense Fund, Gavi, Merck, Pax Sapiens, Philips, Reckitt, Seed Global Health, and Viatris. We're going to do a lot more programming at FP at COPS Forum and in Health at the COP Forum in Baku coming up in late November. So please do talk to myself or one of our team members if you're interested in that. We'll also be at Davos in January. And I wanted to let you know today that we have scheduled the FP Global Health Forum on May 26th next year. At the Intercon. That is going to be at the WHA. We did a big closing event to close out the WHA. It rocked. So we hope you can join us for that too. And then we're going to have more programming here tomorrow. Join us on Thursday tomorrow, where we're going to have an energy program in the morning and a food program in the afternoon. A lot of the topics will kind of connect to health as well, just as they did today. We put out cards for you to subscribe. Did anybody become a subscriber? Raise your hand. Everyone raise your hand. Please subscribe if you haven't. And I just, again, wanted to thank all of our speakers and audience. And I also wanted to thank all of the folks on the live stream who tuned in. Thank you so much for joining. Let's give them a round of applause for tuning in. Now that we got rid of those people on the live stream, we're going to have a cocktail reception that is going to be co-hosted by me and FP and also Guard P and GSK. And that is on the eve of the high-level meeting tomorrow on AMR. And this reception is going to spotlight the critical funding, research, and policy efforts necessary to ensure equitable and sustainable access to antibiotics. But first, before we do that, I wanted to invite Dr. Monica Balasagaram, who was just up here a minute ago, to make a few remarks, to chat a little bit about all the good work they're doing and take it on home. Monica, please take it away.
Yeah, so I won't be chatting about all the good work we're doing because I could be here for a very long time, and I think you all want to go for the reception. So thank you very much, Andrew, and thank you very much for the Foreign Policy for really doing and hosting this excellent event. I think it's a fantastic location, as I'm sure all of you would agree. I'd also like to thank Dame Emma and GSK for also sponsoring this event as well. So I think it's really great to have the support of partners who are not just partners in financially, but also thought partners in the work that we're doing. I would like to just say that we don't know what's going to be happening in tomorrow's high-level meeting. But I think it's clear to all of us that we really need to move forward in the work that's ahead of us. And we really look forward to working with many of you in the room who are going to be very important partners for us in the future in addressing this issue. Now, before we break for the reception, I would just like to take a moment to thank some of our donors who are here in the room. And if it's okay, I would like to call them up to join us for a group photo. Just to mention that Guard P recently received a very large funding commitment of 60 million from a group of donors, including 6 governments, the European Union, the Bill and Melinda Gates Foundation, and the South African Medical Research Council. So first, I'd just like to ask, and I think Dame Emma has actually left, so I'd just like a colleague from GSK to join us on the stage. Lauren Michel from HERA, the European Union, Muna Abusin from the German government, from BMZ. And I would just say Germany's remains Guard P's biggest funder and supporter right from the time that we were set up in 2016. Someone from the UK government. I don't think Dame Sally is here, but if Anna Weshberg is here, please do join us on the stage. Padmini Srikantia, please join us from the Bill and Melinda Gates Foundation. Professor Ntusi, who is now the president and CEO of the South African Medical Research Council. And I would just say the South African Medical Research Council is not just a funder for Guard P, but it's a really, really important partner in the work we're doing in South Africa in general. Has been a partner of Guard P since our inception in 2016. Vice Minister Marilyn Sonema from the Netherlands, please do join us. Alexandra von Kessel from Switzerland. Alison Kalem San Giorgio from the Monaco government. And last but not least, former Minister Shiozaki from Japan. We'd be very honored if you could join us on the stage as well. So I would just like you all to give a big round of applause to all our supporters and funders. I have to say, I have the nice job of doing the really interesting, exciting work, but none of this work would be possible without all of you here who are thought partners, who are funders, and actually collaborators in many of the project and work that we're doing. So a big thank you from the bottom of my heart and from all the Guard P team.
And Monica, if okay by you, congratulations to everyone. But we can excuse the audience. You can go. Please get your drinks and then we'll have some more discussions, and you can do your photography. I'm sure you'll want to do a few. Do you want me to be in? I don't know. Did I? Am I donating? Okay. Yeah, I think that's a good idea.